Good morning, everyone. I hope you all had restful sleep. We're going to try to get going with the session today. That should be very interesting. We have some, I think, very interesting global discussions. So first of all, my name is Mirza Alas Portillo. I am currently a consultant with the South Center that is based in Geneva. So I have the pleasure this morning to, I'll briefly introduce our speakers because you already know some of them. So we will have, starting today, we'll have a presentation by Viviana Munoz, who is, as was introduced yesterday, the coordinator of the Health, Intellectual Property and Biodiversity Program at the South Center. So Viviana, if you want to go ahead, we can start with the first presentation. We'll do the presentations together and then we'll take questions at the end. Each presentation is around 10 minutes, and Musonda very kindly has agreed to use the bell to remind you to wrap up. So, yep, thank you.
Good morning, everyone. I will do my best to keep to the 10 minutes, but I do appreciate a reminder then when we're getting close to time so that we can keep to schedule today. Yes.
It's already ready. So
I think it's this one over here.
yeah. When you're ready, click first and then start. Let me do it for you. Go ahead, name the buttons.
Okay. So my presentation will be basically setting the scene for the subsequent presentations that we'll have during this panel. And what I will be talking about is really what are currently some of the important international level processes that are focusing on how can we drive global collective response on antimicrobial resistance. We all recognize the threat of drug-resistant pathogens, but there is a challenge within all the different global health risks. But how do we keep the issue about antimicrobial resistance really high on the agenda at the highest political level in our countries? And how do we mobilize sufficient cooperation and coordination that we need in different areas towards the actions that are needed? So I think as a South Center, we're well placed in this discussion. We're currently participating, assisting our member states that are over 55 developing countries from different regions in negotiations in several of these processes. So I hope that for some of you, it will be new information. For others, it will be very basic for those that are already involved in some of these processes. But the idea is that this will help be just the basis for all of us to then participate very actively in what will be the breakout sessions later today about how can we provide as part, as with that knowledge of the local needs and the local context here in African countries to feed into these discussions, to tell, for example, the policymakers that will be involved in those negotiations of, well, what are priorities, what would be key issues to have reflected in some of these important processes that will be taking place, in particular with outcomes next year. So the timeframes are quite short for the processes. So it's really an invitation for all of you to engage and seek to engage with your own policymakers to provide feedback to these issues. So the general context is that, of course, the most of the actions we need to take are really at the local level. So from local to national, and then we have regional level frameworks. For example, the African Union, more recently, as we heard yesterday from Africa CDC, mentioning that there is a new framework on antimicrobial resistance for the next 5 years, setting some of the ideas of where our priority areas and where investments are needed. At the same time, we have the international institutions, which are those where a lot of the global priority setting is established, and then the global action plans that are developed. So as you know, there's a global action plan in antimicrobial resistance, the latest one being 2015. And now that is in the process of being considered for revisions. So we will be entering that process also of updating the global action plan in AMR. It started really as a process where it was centered on the World Health Organization. So very much from that perspective of public health. And then there's been the effort to strengthen the collaboration with other actions and noting the use of antimicrobials both in animals and in environments more recently. And so we have the World Animal Health Organization, as we heard yesterday, the World Food and Agriculture Organization of the United Nations, and the UNEP program working together. So that's the quadripartite now. And so a lot of the things we see now coming in terms of guidance and policies are not only from the World Health Organization, but actually now that are supported overall by the 4 institutions. So that is a very welcome development in the recent years, which has been really much more collaboration between those international agencies. And why that is important in particular in the context of our developing countries and for Africa is that then we see that these institutions are really core providers of technical assistance and capacity building. So really the increased possibilities for these institutions to provide assistance is really important. And the more they have coordination between their sectors, it will be more helpful also to facilitate that local level coordination between those relevant sectors. And of course, there's still discrepancies. But I think the fact that we see recently from last year, for example, a new plan, a coordinated plan between agencies with common priorities is quite useful approach. So there where we have is really technical guidance documents that then get trickled down and let's say put into the domestic context, but they're useful elements for that, and then the capacity building. Then there's been efforts to ensure that there can be also more direct participation or representation of different stakeholders that are important. So recently there's been the establishment of the Global Stakeholder Platform. This was just announced in May this year. So this is also an important place where perhaps you might want to look at for direct participation. It's open for applications, and there will be specific working groups on different topics. There's one body that will be, for example, for civil society, and there's also for private sector and for other actors. It's not clear exactly how it will operate, but these working groups will be providing at that high level some let's say, input to these related processes. Then another important element has been the effort to keep the high-level political momentum for the issue of action in AMR. And there was establishment of a global leaders group on AMR. So this is the head right now is the Prime Minister of Barbados. There's different representatives. For example, there is from Nigeria, the former Minister of Health, as well as I believe from Uganda, might be who's currently someone from, I think, Ministry of Environment, if I'm not correct. But that the point of that group has really been to try to keep activities at a very high level. And the reason for that is really because what those that are participating in terms of policymakers in the processes, which are WHO, FAO, OA, and UNEP, will be more at the technical level. So we might have ministers of health coming to the World Health Assembly of WHO, but that's once a year. Then the rest will trickle down at technical level. And where we need, for example, support for investment, for mobilizing resources to the programs, have necessarily might have to come from other ministries and potentially higher level. So political support really has, for health issues overall, in the past decade, has also moved to United Nations General Assembly. And that's because there you have a meeting of high-level political leaders. So you have heads of states. You also have ministers, which include ministers of finance and others. So the fact that health issues have moved to the UN General Assembly is very helpful, in particular to start seeing health overall, health investment as a core issue that supports overall development, and particularly things that are global challenges such as AMR, as drug-resistant infections is a challenge for the whole world. It's not only for particular countries. So in that space, that is another level that sometimes it seems quite far off. You know, how will that assist our goals here, and we're at the national and local level? But the fact that we might have presidents, for example, or prime ministers making those commitments to invest in these programs can be quite important. So with that context, let me just note that in 2016, there was for the first time a UN high-level meeting on antimicrobial resistance. There has been other high-level meetings on other health issues, but never specifically dedicated to antimicrobial resistance. This was quite significant because this was a year after the Global Health Strategy or the Global Action Plan in AMR. And there was a need to really bring up the level of interest at that very high political level about what actions needed to be taken with regards to the threat of drug-resistant infections, and particularly avoid the emergence and spread of such drug-resistant pathogens. So one of the core elements was a linkage that was made directly to the 2030 Sustainable Development Goals. And there we know there's a SDG on health. We'll probably hear more about this in other presentations, but AMR had not been placed at all in that context. So this led to a declaration that all those UN countries, which means that the whole, basically the whole countries in the world, have agreed to, which makes, first of all, that linkage. It's recognized as a core development issue as well. It highlighted the need for a multi-sectoral approach, so One Health. That was not necessarily too strong or too prominent in the Global Action Plan in AMR. It highlighted the need for resource mobilization, and there was a particular mandate to find mechanisms to mobilize resources. And of course, as you know, we're still in that process. There's an important note to the need for capacity building, technology transfer, as well as technical assistance for developing countries. So that's a commitment already made in 2016. A critical issue that was discussed was the need to ensure that there would be assured access to antimicrobials when they are needed. And of course, that also tied to ensuring that there is adequate stewardship or prudent use. But access was seen as a core element as well in the framework of ensuring. So you'll see here other elements. Another just to note was that there should be a global development and stewardship framework, which that was negotiated, not to say that there should be an international instrument or something binding, but that there should be more than a global action plan in AMR. There should be something more concrete, and that all these areas should be covered, including the issue of access and research and development for new antimicrobials, in particular antibiotics. That process did not go after several years of negotiation. There hasn't been any development and stewardship framework, but now there is the discussion as part of the pandemic instrument that's being negotiated in WHO, whether those elements of, let's say, more concrete global commitments could be included as part of that instrument. So I'll have to go very quickly through this, and just to note that there's 3 upcoming meetings that are quite important that are not an AMR, but there should be an effort that we try to advocate that AMR should be integrated into all other efforts that are related, in particular, for example, on pandemic preparedness, prevention, and response. We'll hear more in other presentations specifically on the linkages on AMR with this area. Tuberculosis, we know drug-resistant TB it is a significant challenge. We have about 33% death rates in terms of tuberculosis in the African continent. Universal health coverage. How do we integrate AMR as part of those efforts on UHC, including on access to antimicrobials, which will avoid, of course, levels of common infections by adequate treatments. And then we will have a particular dedicated high-level declaration in September 2024. So that's part of the invitation of how do we provide inputs to that. Now, some broad themes for thinking of what comes up for the high-level declaration is we need to renew the political support, specifically post-COVID. It would be important to draw back the attention to drug-resistant infections, review which are the current global commitments. As I mentioned in 2016, that declaration already has a lot of important language, but how do we actually say, well, how much did we achieve there? So we're not actually reinventing the wheel or asking for new asks, but there is more that just to build on of what was there. Concretizing the existing commitments. Now, there's a lot of discussion about potential targets. And I think that's something that the working groups would be interesting to see what could actually work. I mean, global targets can be perhaps very broad, and they need to trickle down is really to the national context and what is actually doable. For example, what does the African Union framework say in terms of potential targets that might also suggest what might be relevant for the African context, and some approaches, what would not necessarily be adequate. And the other issue about increasing support and resources, in particular overall funding to the area of AMR, in particular for developing countries. Then just to note, there's two important relevant negotiations going on in Geneva, both in terms of international health regulations, which relates very much to health security. And while there's no mention directly to antimicrobial resistance, in practice, when there is a review about the assessment of health capacities under the IHR, AMR is already a subject. So that's something to remind to say, well, even when we're talking about adequate implementation in the international health regulations, which are mandatory regulations in all WHO parties, AMR should already be part of that concern of implementation. And then on the international instrument, there's prevention is one of the areas of the scope. And of course, if we're talking about preventing pandemics and overall outbreaks, well, of course, we know that there is a role about how there should be an integration about the threat of drug-resistant pathogens and what can be some actions that might be synergetic in both areas. And this will be discussed more later. So any efforts that we can make as well to integrate and say why AMR has a role in this area would be important, in particular from the African perspective. More of this will be discussed later, but this is just early on. This is, for example, from the 2017 working group on financial preparedness, where already there was, these common elements from preparedness to health emergencies and what is needed for Action AMR. There's many areas that can complement and be synergetic. And I just added to that the issue of access to therapies, diagnostics, and vaccines is an additional area that's very important. But we know, of course, that on the prevention measures, many are synergetic, and that'll be discussed further. Just to note that in the pandemic instrument, and I'm finishing with this, an important element is equity for how do we have better prevention, preparedness frameworks, and response to pandemics. And a core part of equity is how do we ensure that we have access to adequate medical products, which includes medicines, but as well vaccines, diagnostics, and others. We know that there was an enormous delay in access to vaccines in developing countries, problems with supply chain, and so forth. And some of these issues are also relevant in the case of existing and new antimicrobials. For example, if we do have new antibiotics coming into the market, how do we have an assured process both for stewardship in developing countries, but also to ensure that there will be access? So there's ideas, for example, on new procurement process. I'm sure Gart P could speak more about this in detail, but just to note, that this area of equitable access to medical products is one of the centerpieces of the pandemic instrument, and it can also be a related area of where the entry point for some of the issues of AMR should also be considered in that context. Finally, just leaving for the presentation, you can see many of the publications that we've been doing, analysis on those issues. Thank you very much.
Thank you very much, Viviana, for taking us through some of the global processes. I think, as Viviana was mentioning, and part of the exercise that we will do after with the breakout groups is also to think about what should be some of the priorities that should be reflected in the new declaration. And also, as she was mentioning, how much of the previous declaration and the ambition there was actually achieved, and how much of that we should also be pushing forward, especially I think with elements regarding to access, as Viviana was mentioning. I think this is an important issue. And even though sometimes we feel that these things that are very high level don't necessarily translate to the local or the regional, but I think they do have a mandate, and we can see in some processes that they do, they do help with, especially with the mobilization of resources and sometimes as well the direction. So I think those elements are very important. So now, as we build on these global processes, we're going to have a presentation by Mervyn Mapundo, who doesn't really need an introduction, but is the director of ReAct Africa, and he will take us through some more of the elements on pandemic preparedness. So please go ahead.
That's it. Yeah, that's it. Thank you so much. Good morning, everyone. It's quite exciting to see that we have come back for day 2. How many pandemics do you think we have had in the last, the beginning of time? Yeah, I'll try and run us through some aspects in terms of really how we can be able to rise to the challenge of really preparing and being able to manage really pandemics. So we have had 249 pandemics through history from 1,200 BC, before Christ, up to COVID-19. And pandemics are such that, such as actually Spanish flu. When you look at this, my next slide, not moving. Okay. So when you look at this slide, you will be able to see actually the rich history around pandemics. And unfortunately, we talk about the plague, the Spanish flu, we talk about HIV, Ebola, we talk about, basically the swine flu, and we see the death toll that actually these have had over the years, that we've actually been able to have some records in terms of pandemics. There's been a greater shift actually in terms of humans being hunter-gatherers, of course, in the agrarian basic societies, which started around 12,000 years ago. And of course, there's been an expansion in trade. We have also seen basic populations increase, both human populations and animals. But with that also has come actually transmission of a number of diseases, and that, of course, we have also experienced plagues. And of course, the climate change has had an effect on that. But also, we have seen the persistence of actually pandemics historically through history, and though there has been a reduction because of improvement generally in the health, actually status of health, we still see pandemics, and we'll continue seeing actually pandemics. And the global surveillance programs really of waterborne pathogens, they've played a part, and the vector-borne pathogens in terms of really showing us the spillovers and the impact and the importance of being able to rapidly dictate the pathogens that we are dealing with when we look at pandemics. So really, COVID-19, there's a lot that we learned around COVID-19, and I think we all know a lot about this. We were unprepared as a global community. We saw that there was an impact, not just on mortality and morbidity, but there was an impact in terms of economies of nations and countries, a decline in 2020 of about 3% or so. And the US lost about $14 trillion. That was expected by the end of 2023, but has actually already happened. And of course, a number of people were moved, driven into poverty, and making them really at risk of getting infections. Employment, a lot of people lost jobs. And when you look at the past outbreaks and the economic burden or consequences that they've had, let's look at 2003, the SARS. We had over 8,000 cases and 774 deaths, and the toll was about $52 billion US. Ebola, again, we saw the loss in GDP of 2.8 billion. Zika, again, there we saw about 3.5 billion. So we constantly see that really pandemics, when they occur, they not only affect our human life, but they also affect really the economies, and they affect and move some people into extreme poverty. Inequalities are something that we continually see in societies today. And inequalities actually drive AMR, and also AMR drives inequalities. There's a vicious actually cycle. And so we see people being driven into poverty. And those driven into poverty are more at risk of actually getting really infections. And when we've got a pandemic, makes it much easier to actually spread at a faster rate. We still have issues around the hospital settings. I think yesterday I had talked about this in terms of the healthcare systems, that really 1 out of 3 hospitals don't have any running water. Whichever country you go to, in a capital city like this one, you find water in drums, dry running taps, and that actually really pushes and makes infections to be able to spread at a faster rate, and really exposes people in communities. And we have focused for so long on health institutions, really forgetting that the greater population are in the communities. When one looks at a population like of Zambia, closer to 20 million, and we say, let's argue that the beds in hospitals maybe 6,000 or so, then you're talking of really 14 million people in communities that may not have any safe and clean and running water. But one of the issues that we'll talk about in the afternoon, in my presentation on gender, will be to show the disparities and how that AMR affects gender in a different way. But we also see that with inequalities. The elderly, the children, the adolescents, the migrants, they're affected differently. And these are the ones that end up actually, with a high burden in terms of pandemic. This graph is showing us really the Global Health Security Index report that was released in 2021. And you can see, some conclusions here that really all countries, regardless of income, were not prepared, and the capacities were quite weak. they need to be strengthened. And so, both high-income countries, low-income countries, we needed to strengthen that. And this report also, labels all countries as dangerously unprepared for pandemics and also for epidemics. Management of zoonotic diseases risk has the lowest scores, really followed by surveillance and reporting. The report also demonstrated the large gaps in what is available in terms of health capacity, in terms of human resources, in terms of the strategies that are actually available to manage and contain. And so all countries basically scored really poorly, with an average of 30 out of 100 score that was used. What are really some of the key actual shortcomings in global actually response in terms of really COVID-19? And it's still active. People are getting infected. So our weaknesses in the global surveillance was one major one. Really, coordination was a challenge. Really, lack of investing in research and development and making really diagnostics available and also vaccines available. And the PPE equipments were not available. In some of the institutions that I worked in some countries, nurses were actually given one pair of gloves at the start of the shift in the morning, and they were going to work 12 hours or 8 hours. No changing of those gloves because there were no gloves in institutions. And there were no hand sanitizers, and you don't have running water in those institutions. So how do we prevent that? Our public financial management and procurement systems were inadequate, but also something that we don't address in the African setting and in our context is the issue of what leaks out of the system. We saw very, very bad and also, very disturbing reports around the COVID funds that never ended up really being used for COVID, but they ended up leaking out of the system in people's pockets. Really collective action was quite bad. And, through that, the Africa CDC, Dr. Wande will talk about this, I think, in a bit of more detail. They've come about with really some initial initiatives for the pandemics, and they did that for 2019. And some of these are actually applicable even for further pandemic. Really having this joint actually strategy basically for COVID-19 and other pandemics. To have a task force that will respond fast. I mean, partnerships that would actually accelerate testing, and also really having consortiums in terms of clinical trials for actually vaccines. And lastly, being able to look at the issues of saving lives and the economics by really working together as a global community, but also more especially as a region. What are some recommendations actually quickly that are important for us to consider? We need to strengthen global collaboration. We need to be able to work, with the private and public sectors, international partners for, a joint containment of treatment and vaccine development. We need to share insights, data, and we should be able to predict and counteract the spread of disease more effectively. We need to promote also local solutions and recognize the potential of homegrown solutions. It was very interesting that, every airport you landed in Africa, every shop that you were going to go to, there was a bucket of water, and they had some hand sanitizers in most of the shops or the malls. You could not get into a mall. So, those were local solutions, and it's possible that that can actually be done. We need to really solidify emergency preparedness and also look at the economic resilience. And that would involve really creating comprehensive emergency plans but also really establishing financial reserves for both these health emergencies, that would result in minimizing the economic impact, but also that will provide resources for us to be able to actually address and be ready for pandemic preparedness and readiness. And really, we need to have a community-centered a response that takes the cultural, religious, and economic, basically indices or indicators in the solutions that we are trying to put across. We need to involve the communities in the decisions, empowering them and raising really health literacy, because that is actually fundamental in having them to actually have a say in their own health and also being able to actively participate in preventing these pandemics and containing them. We need to strengthen our healthcare services. I mean, that's something that we've talked about here. Yesterday, we talked about the diagnostics, but those are major issues. And yesterday, again, we looked at the Graham report and what it has revealed. So in my last slides, I think it's important that when we look at the next pandemic era, and as we still face the COVID pandemic, a number of people are still actually getting sick. My daughter was sick last week, and so it's still not gone away. We need to ensure that there's equity, there's trust, there's communication. We have to prioritize interventions that build in public health guidance. We need to include marginalized communities that suffer the most, those living in the slums, the elderly, those with disabilities. It's important that we take those into consideration. We need to focus more in preventing infections in communities, not just in the healthcare setting or in the food systems. We need to do that far much larger in communities. And I know that my friend Mark is going to talk about that a little later. Workforce expansion is key. We lost a lot of healthcare workers. And some of the healthcare workers in countries like the US, they've been burnt out and they've left, nurses have retired, doctors have left the profession because they couldn't take it. Data was talked about yesterday. Again, we need data to work together. And also we need basically product, really innovation and thinking ahead. So it is important that science actually guides our solutions. It is important that we are expectant that there will be another pandemic. That is a guarantee. There will be. They've been. They'll continue to be. And we have to ensure that we stop the next pandemic, or at least we are able to contain it. And of course, lastly, we need collaborations, not just international collaborations, but we need country, regional, really collaborations, as we see that our interests in the global south sometimes don't align with the global north. Thank you.
Thank you very much, Murphy, for taking us through some history to remind us of some reflections and I think some important learnings that COVID has given us, but also to think about what we want to see when the next pandemic arrives, but also just in general, strengthening our systems. And I think what you mentioned on local solutions is quite important. So now we're going to have our next speaker. She is joining us online. You met her yesterday. So Yowande Alimi, she's from the Africa CDC. She will be joining us now online to provide the presentation. Please go ahead.
And thank you very much. Good morning, colleagues. Please confirm that you can see and hear me clearly in the room.
Yes, we can hear you and we can see the presentation, but it's in presenter mode, I believe. Oh, okay, now it's great. Thank you. Go ahead.
Thank you very much. So the team has asked me to do quite a lot in about 15 minutes. One is to tell the African story. in light of the COVID-19 pandemic, which Mefrin has done a fantastic job setting the scene, but also to bring you a bit closer to why AMR is really a pandemic and not so much as silent as we have all imagined it to be. So really, it's us preparing for this pandemic, AMR, on the continent, borrowing some lessons from COVID-19. Really in alignment with this conference is leaving no one behind, leveraging regionalism was an approach that the COVID-19 taught the African continent. So I take you back to the year 2020. The time is February, January, when the rest of the world start reporting their first cases of an unknown or a novel coronavirus. The first case reported in Morocco, Egypt, slowly spread into Ghana, Nigeria, and before we knew it, to the rest of the continent. Immediately, there was an emergency meeting of the ministers of health of the 55 countries of the African Union. One of these critical moves by the African Union is what really channeled the leadership and the approach used for the COVID-19 pandemic. So like Murphy really highlighted, our approach was very continental, Ubuntu spirit, making sure that not a single country, not a single region was left behind in this process. We approached this really having the highest level of commitment by the AU Bureau of Heads of State. This is quite important, and I really encourage everyone in the room to think about this model for addressing antimicrobial resistance. A few things beyond surveillance, infection prevention and control, thinking about research were really addressed. Thinking about having a financing coordinating mechanism, ensure that throughout the 3 years of the response, we were able to mobilize effective resource mobilization and finances. Addressing issues like transport and logistics, which is a model that we haven't really adopted prior to this, thinking about Ebola, thinking about other outbreaks that the continent has explored. But this was particularly crucial in terms of when the global supply chains were completely closed. We were then able to ensure that we were able to open transport and logistic channels to ensure that key supplies and rapid responders were across the different countries. Also leveraging the Health Coordination Committee, ensuring that policies such as travel bans, because a country reported a new strain following genomic sequencing, our continent was speaking in one language, means that in terms of guidance, it was really driven by the data and policies coming from countries. In addition to that, of course, we use things like leveraging the best of the best technical experts from different countries in line with our different pillars as an EOC or an incident management structure will look like, but really not forgetting the regional economic communities and the role that they can play in addressing any sort of pandemic issues. One of the things that this bettered was our new call to order for a new public health order. And it's quite simple based off the lessons from the COVID-19 pandemic. The new public health order for Africa calls on a strengthened continental agencies such as Africa CDC, as well as national public health institutes, ensuring that we have expanded manufacturing of vaccine, diagnostics, therapeutics, as well as other required supplies for pandemics. Investment in public health workforce and leadership program, a call for increased domestic financial investment for health, and lastly, respectful action-oriented partnerships. So very quickly, I'll try to show you some of the successes and how we as the One Health unit have modeled it to respond to antimicrobial resistance and to guide the work we do going forward. It goes without saying that it is impossible to respond as a country to any outbreak. It might not even be a pandemic, but any disease outbreak, or even prepare for any outbreak without strengthening public health institutes or national agencies. We call for a strong continental regional public health institutions, which are critical to ensure that we can harmonize and coordinate public health responses. We highlight some of the collaborations that we had during the COVID-19 pandemic with our partners, such as WHO and several other partners that we worked with to support countries across the different regions. It's also important that we have strong national institutions that can set priorities, guide programs, integrated efforts, standard settings, and surveillance. But lastly, I think this is a crucial aspect that I call upon AMR experts to really think about how we can work together on this. And that's leveraging regional assets and resources for better coordination. So my next slide, I'd just like to show you what we imagine or what we are doing in terms of leveraging regional assets. As many of you may be aware, we have regional coordinating centers, the Africa CDC RCCs, across the continent. So we really leverage their coordination with regional communities as well as technical partners in different countries. So how can regional assets work? I take you to Central Africa. And this highlights what is already existing within that region. As you can see, a few countries have strong laboratory systems already in place, but you can see that there are countries that do not have any national sort of laboratories in place or not as strong as it would be able to respond to COVID-19. So what did we do? We then created this model, what we call the Regional Integrated Surveillance and Laboratory Network, the RISNet, whereby countries can have shared resources based on what the assets are within the countries. So we put in place things like regional referral mechanisms, shared laboratory systems for genomic sequencing, as well as bioinformatics, as well as things as you'll be thinking about things like EQA. So it's really to build collective and regional-wide capacity for disease surveillance, preparedness, and response. I bring you to what we have tried to apply when it comes to antimicrobial resistance. Through the support of the Fleming Fund, we received a regional grant together with ASLM to really strengthen the quality of AMR data from the continent. Prior to this, NICD was the only EQA provider and regional collaborating center for WHO on EQA in Africa. So this means that the most of the other countries would ideally send their PT panels to places like the UK, Denmark, and other European countries, or sometimes as far as North America to get their EQA results. So with this grant, what we were able to do is set up regional centers of excellence in Dakar as well as in Kenya to increase the availability of this PT panel and external quality assessment for AMR testing. We have also developed a guide to give countries on how to establish their own national laboratory quality framework, but also to guide in terms of sample referrals and collaborations with the regional centers of excellence. Similarly, I like to highlight things like capacity in terms of the lessons from COVID-19. The time is 2019. About 7 countries or 7 public health laboratories had the capacity for genomic sequencing. COVID has created a case for us. Of course, it was natural. We didn't have to do a lot of convincing. Countries saw the value of genomic sequencing, and we were able to leverage partnerships to ensure that we can build up or scale up the continental capacity for genomic sequencing. But what next after COVID-19 pandemic? Now, one of the things that we are doing is creating an ecosystem in Africa for things other than COVID-19. Think about AMR. For example, earlier this year, the work they have done with cholera outbreak, malaria, and other pathogens. One of the questions that was asked was around how data can really drive policy. In some of the country level data you have seen from the map, this is the pathogen distribution, and you can see that Klebsiella species is one of the highest reporting pathogens across the different countries. So what we have done now is we have leveraged the genomic capacity on the continent that was being used for COVID-19 to create a use case for antimicrobial resistance. And what are we then focusing on? Neonatal sepsis. it goes without saying that this can really drive policy advancement on the continent. Already, Africa is behind when it comes to the SDGs as related to neonatal sepsis. Klebsiella is one of the most commonly detected pathogens on the continent. And of course, we are then able to create a case for cost-effective interventions such as IPC and WASH. Moving on quickly, I look at public health workforce, and really it goes without saying, many of you in different meetings have really highlighted the need for a stronger health workforce on the continent. For us to effectively address AMR, we really need to think about how to invest resources to close the significant skill gaps in our public health workforce. I give you an example of what it currently looks like across the continent. You can see the gaps around the community health workers, the field epidemiologists, as well as the frontline epidemiologists available. So just to highlight how we as Africa CDC and really encourage countries to think outside of the box, outside of the sort of the four walls of training that you may be familiar with, and really adapt innovative models to ensure that trainings can be brought to the healthcare workers as quickly as they need them. So one of the things while the world was shut down that we did was really adapt a holistic approach to ensure that we are able to provide these trainings. It's really thinking around how do we leverage regional mechanisms for regional trainings for healthcare workers that need them. We also used a different approach for the first time, really moving from a physical level of training to moving into virtual certification trainings. And my next slide will just show you the impact of what this can be. So it's really important. Every time I'm in meetings, there's a lot of concerns around workforce, what can be done. But it's really time for us as an AMR community to really start to think about models that work. ASLM already has what they call the Lab Cup. I'm aware that Eastern Africa has a model, for example, thinking about the eco sessions on AMR. These are opportunities to really continue to improve workforce development across Africa. So just to show you one of the things that we have done around qualification, this is together with the Fleming Fund and ASLM, is really to create that market for AMR workforce development, whereby we have qualification of AMR surveillance and epidemiologist experts that can continue to go through continued professional development acquired over 3 years and become the skilled workforce the continent needs. In addition to that, we have also launched our international exchange on AMR surveillance to ensure that there's a lot of South-to-South learning. This is part of the lessons from COVID-19 that sometimes what we really need as a continent is in the continent. And all we need to do is have better coordination mechanisms and better inward looking for this. Around local manufacturing, like Murphy has really highlighted, we have really taken that step to the highest level. This is the president of DRC, the former AUC chair, who launched the Partnership for African Vaccine Manufacturing, really to ensure that not just vaccines, but we are able to ensure that supplies are readily available to ensure public health security through a sustainable development and manufacturing ecosystem for Africa. So really, very quickly, this framework really gives what AMR really needs. That coordinated approach, ensuring things like antimicrobials, IPC supplies are readily available, boosting local financing for local manufacturing, increasing momentum of technology transfer, ensuring that we have effective harmonized regulation, local R&D capacity, nurturing and growing African continent, but most importantly, ensuring health systems are stronger by improving basic infrastructure in place. So these are just some of the examples. Prior to COVID, we had limited local production of diagnostics. I was in a meeting last week and there was a lot of concerns around local manufacturing of bacteriology supplies. And these resources are already existing in the continent. How can we move, particularly when we think about AMR, move towards this approach where we have local diagnostics for testing, for bacteriology testing on the continent? Similarly, I need not to convince you about the importance of IPC supplies and local manufacturing, but this is already what exists on the continent. It's now left to us to really harness those resources to really move our local production across the continent. In addition to this, I think African Union has really created a platform for pooled procurement, and we really want to see novel antimicrobials coming onto this platform. We want to see diagnostics coming onto this platform as well as PPE. So really around creating enabling environments for AMR and R&D, many of you, COVID was really one of the push that made our countries ratify the African Medicines Agency. What does this mean for AMR? It means that now we have a treaty in place that can ensure that falsified substandard drugs are no longer within circulation across our different countries. It means that we can put regulations in place to ensure that the most effective antimicrobials are getting to the people that need them. Really, it goes without saying that for us to really address this pandemic as we address COVID-19, we need African-originated, African-defined priorities. We need better coordinated partnership. We need to align with continental priorities. For example, we keep saying AMR is a challenge, but when we want to go to our heads of state, we don't tie them to the commitments that they have made. There's already the Agenda 2063 that the African Union heads of state are working night and day to achieve. How do we anchor this message to this kind of continental priorities? Trusting and effective partnerships, and we're really glad to start seeing that now. Many years ago, it was a global, not driven priorities, but we are seeing African researchers really take this to another level, and AMRCCs are defining where their priorities should be. Also, lastly, it's around mutual benefit and understanding.
Could I please ask you to wrap up? It's been 15 minutes.
Sure, I'm just going to wrap up now. Lastly, I think it's around domestic financing. I mean, the presidents in Abuja declaration have really made this commitment. But one of the things that we were able to do with the COVID-19 and we can really adapt to the AMR is really that direct call, whereby we can, for example, we keep saying invest in AMR, but what exactly? We need to make clear targets, such as if right now our capacity on the continent for testing is at 1.3%, we then call for domestic financing to move us to a certain percent, like 50% bacteriology available. If we have limited IPC expertise, we can make targets that can drive sort of where the priority should be looking at. I think I'll finish with this slide now and say, really, our priorities has been stagnant for a while. We cannot continue to rely on external funding. It's time for our government to start to put investments that can really drive and control the AMR pandemic. So I think I'll stop here now, and thank you so much. And over to you, Madam Chair.
Thank you so much. That was, I think, very, very insightful presentation, because we will have time after for the breakout groups to discuss some of the themes that have been emerging on the presentations. But since Yuande cannot, join us there, I might take two questions very quickly while we still have her online. So I have one at the back. Yeah, please go ahead.
Okay, thank you. I'm John Mumbo from the environment side. I'm really concerned because I think from the three presentations, I've not heard anything being mentioned about One Health, or maybe anything being mentioned about environment. From my perspective, we really need a radical change in our approach to AMR in Africa. We need to have a one health approach rather than what we are seeing from this presentation, rather than interventions which are health related and just targeting the health sector. What I mean about this, you see, all the presentations are focused on health related interventions. They, looking at the presentation that was made by Muffin, he made it very clear that about the sources of this pandemic, when you're talking about Zika, SARS, Ebola, even COVID, they have an environmental aspect. Let me put it, they have a contamination. They have a, you call it in the health sector, a water health, something sanitation approach. All these things find themselves back to the impacts that these sectors have caused on the environment. Why can't we have this? Why can't these recommendations, rather than being curative and health related in nature, why can't we have them being preventive and One Health or ecosystem related, in approach? So that's actually what is really missing in all the presentation. They're just all focused on health. That's my take on it. Maybe I don't know what they'll say about it.
Thank you for the question. I think it's a fair reflection. Do I take one more in the back? Do we have any questions online? Okay, so just that one in the back, and we'll give Yewande 2 minutes to reply it, and then we move to the next presentation. So please go ahead.
Thank you. I just wanted to, my name is Shapiro from Zimbabwe. I wanted to find out from one day in terms of the African Union program on promoting food procurement, because I think this is a very important aspect of enhancing access to medicines. So yeah, I just wanted to find out what the African Union is working on towards achieving that goal. Thank you.
Yewande, were you able to hear the questions?
Oh, yes, I did. Really good. The first question was fantastic. Indeed, if the presentations don't highlight One Health, we probably need to revise what we're doing. But I think allow me to make this sort of feedback on behalf of the organizers. I think one of the things that they thought about showcasing in this is we have to agree the impact of COVID-19 was really impacted the human health sector. It impacted human beings. We lost people, we lost families, we lost friends, we lost colleagues. How do we ensure that AMR, we can leverage the attention of the pandemic? And I think that was the idea the organizers had and really wanted us to showcase. But that said, it's important to also give the opportunity to colleagues to understand that there are other sort of interventions, for example, wastewater surveillance. It was as a result of the efficacy or sort of the effectiveness of wastewater surveillance in driving policies or helping early detection that we are starting to think about how do we expand AMR surveillance using wastewater. So those are some of the gains that may not be showcased in this presentation, but are definitely beneficial. Similarly, when you think about zoonotic diseases, and this is outside of AMR, and I really encourage when we're thinking of One Health, we don't just keep our attention to AMR alone. There are also benefits for zoonotic disease outbreaks. This is how we are able to sort of predict, for example, the Marburg outbreak in Equatorial Guinea and Tanzania. That's how we were able to do the epidemiological linkage of the origin, thinking about it from the outbreak that occurred in Sierra Leone about 6 years ago. So there are benefits when you think about One Health in the whole holistic approach. There are interventions that are very focused to human health, and there are interventions very focused to animal health. But where we really, the synergy is how we leverage those resources. For example, the labs, the veterinary labs supporting COVID-19 testing. This gives us a good idea on how to scale up AMR testing capacity in the veterinary labs as well. So that's just to answer the question. For the pool procurement, this is done with several of our partners, the Afri-Exim Bank. I don't know if colleagues are aware of that, but my slides will be available and the website link is right there. So the colleagues can just look at the pooled procurement. I think for one thing that's quite important for the representatives of the member states there is you drive the demand in terms, rather you drive the supply. Your demand drives. If you're not requesting bacteriology supplies, if you're not requesting PPE, they're not going to prioritize pooled procurement. So I think the use of that platform is really dependent on the interest and the demand from the AU member states. I hope that has answered the question. I'm happy to reach out to colleagues later.
Thank you very, very much. I think that was very, very helpful. I'm gonna go ahead and move to our last presentation for this morning with Dr. Sujit Chandy, who is the Executive Director of ICARS. And prior to this, he was Senior Professor, Department of Pharmacology and Clinical Pharmacology at Christian Medical College, Vellore, India. And he's gonna walk us through some, I think also reflections on some actions on AMR. And after this, we're gonna move to the breakout groups where we can take a lot of these questions in the discussion. So please go ahead. Is there something related to this? Yes, go ahead.
Yes, thank you. It is just a comment. Based on the lesson learned from COVID-19 pandemics, I will suggest if Africa CDC is there, not be focused only on the public health labs. Because in the country, each country, you have, as you said, you have different labs. So it will be good to put in place a task force of laboratory to have exchange with them in terms of preparedness, in terms of capacity building. This is what I want to suggest as comment.
Morning, and thank you very much for the opportunity to make this talk on behalf of all of you in one sense, and also representing ICARS. So today I've been given the responsibility to talk about this particular topic, which I think is very, very important. I was going to ask you a question just like Murphy asked you a question, but then what is one of the biggest problems in the world today? And my guess is that all of you will say AMR, okay? But actually, in one sense, it's evidence. The information overload that we have today is probably one of the biggest problems. What is truth? And that truth, if you go by the definition of research, research is to bring out truth. But in the AMR field, we are running out of time. I'm sorry, I don't have a pointer, but you can see that hourglass and the number of effective antibiotics is rapidly decreasing. What about our children? What about our future generations? And that is the eternal question. What about our livelihoods in every sector that we are here representing? And one of the biggest problems is these gaps between what we do in evidence generation through research, the policies that we form, and the actual practice. And you can see these gaps in the cogwheels. And we need to address this if we need to really push forward with our solutions in AMR. We need to get the evidence straight. What is the real truth out there? But then we need to use that evidence in order for our policy and practice. Are we doing that? In each of the countries that you represent, in each of the sectors that you represent, even in your own town. So as I talk about this, please reflect on your own circumstance. Because if you look at it, there are many factors which are probably preventing this translation of evidence to policy and practice. And one of the greatest challenges is this balance between benefits and harm. Just yesterday, one of my old former classmates in my university medical school sent an article he had written against using generic names and generic drugs as a doctor. And he put a whole list of arguments about how it can harm to put generic names. Now, of course, from a WHO perspective or any other perspective, it is important to use generic names. So this whole issue of what is benefit and what is harm in each of our policies is a big issue. Then, of course, comes our value systems, our context. What is the quality of evidence that we generate? And what does it cost to put these so-called policies into practice? And therefore, we need to ask ourselves in our own context, does the research that each of us do, there were some beautiful projects that were presented out there yesterday in the evening, and all our own individual CVs and projects and research, is it improving people's lives? I can even say animals' lives, plants' lives, our sector's lives, our livelihood. Holistic research is needed. And from a human health perspective, you can easily translate this into every other sector. Does clinical experience alone improve patients' lives? Or is the health system's perspective needed? If you look at farms, do we have the water resources to maintain a farm and therefore prevent infections, for example? And last but not the least, the people that are involved in our sectors, is there a person-centered approach? Is there a farmer-centered approach? A fisherman-centered approach? Do we get their opinions? So whatever we do, of course, there are various research methodologies and ways we can do all this, but we need to clarify that problem first with what we said just in the earlier slide, and then move to benefits, harms, economic issues, and get that together probably through implementation research with the views of stakeholders. But whatever we do, we need to get the policy right based on the detail, but we also need to do it right. Now, what do I mean by do it right? What I mean is, in the process of policy formulation, are we getting the process right in the right steps? Have you ever thought about that? We all sit together, and I've been into many policy-making bodies. We have limited time. We try and put our thoughts together. We try and get a document together, and that's it. And we expect people on the ground to follow it. But that's not how real life works. We need to first acknowledge that research may be lacking in that particular area. Look at your own sectors. What are the issues and needs? And get back into that. There might be available evidence, so please consider that. But we look at the strengths and limitations. We look at each stakeholder involved in the process steps, and are we bringing them into the picture? Then, of course, once that is done, we need to pilot test it, monitor how options are implemented. How many times have you really pilot tested a policy and evaluated its impacts? But this is the slide I want you to concentrate on. In order for good health policy formulation, in my opinion at least, and the authors, we need to make sure that it is understandable, structured, inclusive, but transparent. I already talked about the evidence, but the last three is really in the AMR field we need to do. We need to be rooted in people's issues. Are we? And this talks about disease burden, equity issues, access, health systems, values of people, governance issues. And then we look at, when we do make these policies, what are the dynamics between people who make the policies and people on the ground? What is a researcher's view versus a policymaker's view? What is a farmer's view? And then finally, a lot of policy, where do we pitch it? Global, regional, country, state, village, family. And that's a huge task, because to get everybody on board, it's almost impossible. And that is why we need to, in one sense, make sure that our evidence base needs the context, so that people who apply the policy know, oh, this is meant for this context. Can we tweak it, therefore? So in the second part of my presentation, after getting through the theory in one sense, let's look at some examples of evidence generation with possible policy and practice implications. Now, again, while I do this, I want you to reflect on your own research. This is an early attempt which I did with WHO 20 years back, actually, trying to look at what are the kind of antibiotics used in our urban and rural communities. We looked at 56,000 patients, and we found that in the green arrow, the y-axis is about the DDD per 100 patients, defined daily dose. Fluoroquinolones were the most used. So that sets me thinking, once you get this kind of a graph, why are fluoroquinolones used? Twice a day, very convenient, relatively inexpensive. But the problem on our side, the AMR side, is that fluoroquinolones, the cross-resistance, the very specific use for enteric fever, all was lost because we've been misusing it. And this is mainly used for respiratory infections, where there are other drugs also which we can use. So that sets off alarm bells, but it also sets off, in our world, what should we do to create a policy to prevent its misuse? And that's the way evidence generation should be done. And after that, actually, in our own town, we had some guidelines with GPs where we tried to prevent a misuse of fluoroquinolones. But we can be much more specific. On the left graph, we looked at antibiotic use in urban pharmacy shops or chemist shops. And on the right graph, we looked at rural hospitals. Rural hospitals, cotrimoxazole, that was the only thing available, by the way. On the left was amoxicillin and fluoroquinolones. So we can look at evidence generation. This is a very crowded thing, but all I want to say is that we looked at the top 3 antibiotics for patient symptoms, and fever and upper respiratory, for example, were one of the biggest users of antibiotics. So then let's target those 2 areas and look at policies there. So each thing that we generate, for heaven's sake, let's look at how we create the policy based on that evidence generation. And another example is of ICARS. So let me just dwell on that for a little bit, where we try to reduce drug-resistant infections in LMICs by trying to close this gap between evidence, policy, and practice. But we also have to make sure that it's sustainable. It's across One Health. We need to build on the existing NAPs and be holistic as we do it. This is not an easy task. And many a times we struggle, and I'm sure our partners also struggle, to get these projects through. But it is so important to put that brick as part of the wall in order to contain what we are facing. We have different pillars, but of course, the idea is really to make sure that we try and test some of these context-specific solutions, translate that into policy and practice, and advocate for these kind of projects and solutions throughout the entire world. But we have to ensure that whatever we do is top-down and bottoms if it really needs to work. We need to make sure that there is governmental support and commitment. And then what we try and do is co-develop and execute this through local universities and research institutions. Of course, that creates its own challenges, different groups, different angles, but that makes it much more holistic. And we try to build partnerships. So we have supported the One Health Priority Research Agenda from a global nature, and we have supported ReAct and ReAct Africa in its attempt to move forward with implementation of NAPs. But I just want to show you the kind of projects we're doing worldwide, 32 projects in 16 countries and 5 to 6 more as we speak this year, in different sectors. Some are funded by us, some are co-funded, but in all different sectors. And these are the projects in Africa, and I won't go into it now because Some were presented yesterday through our posters, and some will be presented as we go through the next 2 days. But you can see that there is this flavor between the different sectors, and many of these are based on the need of the country, the stakeholders involved, and try and create a context where we need to do something about that need, that problem, and see whether the solution works or not. And that's our philosophy. But I am going to show you 3 examples now of things that we're doing in other parts of the world, where we try and use the intervention and implementation research to get some kind of solutions. There was a big problem in Colombia where many of the piglets were developing diarrhea. And of course, when you have diarrhea, the first inclination, as humans at least, is to take some medicine to stop it. And of course, sometimes it's an antibiotic. So in 81% of these farms, the cause of diarrhea was not diagnosed, and pigs were being treated with broad-spectrum antimicrobials. They don't know what the bug is. So what we were trying to do there is, try and assess the effect of improved colostrum on vaccine protocols by sort of building a diagnostic network service. And our preliminary findings suggest that antimicrobial use, once this was done, has been reduced. And we hope that this will lead to an adoption of the diagnostic network service in the country as we scale up. And these protocols of vaccine and colostrum are implemented throughout. The second example is in Georgia, where there was a big problem of misuse of antimicrobials in surgical prophylaxis. So their need identified was that. So what we have tried to do with them is to implement and impact some of the surgical antimicrobial prophylaxis guidelines in some hospitals. And what we've again found is that there has been significant improvement once this toolkit was introduced. And we've tried to identify the AMS barriers through that project, because it's important to get the challenges, document the challenges, and learn from the challenges even in other projects. And also see, what is the cost really to do this? Is there a benefit? And we're hoping, and I think that is going to happen, there will be an adoption of this AMS and SAP guidelines in the country. And the last slide is this. In Kyrgyzstan, a huge problem with respiratory infections, a lot of antibiotic misuse. And we all know about CRP, but the real fact is it useful? Is it cost benefit? Can it avoid antibiotic misuse? And the answer so far has been yes, a significant reduction in antibiotic use. And both patients and healthcare providers found a great use for this, and they really want to buy it. So thank you very much for this patient listening. And I implore you that we need to ensure that every research takes time, effort, money, a lot of stress for all of you. Let's make sure that they're context-based. We translate this into policy and implementable practice so that all of us benefit in our move against AMR. Thank you very much for this opportunity.
So thank you very much to our speakers. And as I was explaining earlier, now we're gonna go ahead and do the breakout groups. The idea is that a lot of these, kind of high-level presentations and a lot of these ideas that have been discussed can be, discussed in the groups. We are also trying to think about, kind of priorities and things that we would like to highlight from the African region into the high-level meeting for 2024. And we have divided the groups in 3. So we have access, which will be in room 1, which is right across from here, and whose moderator is sitting right here, Dr. Marta. You can wave so people know this is the moderator you need to follow for group 1. For hospital-based antimicrobial stewardship programs, they're in room 4, which is downstairs, and that the moderator is Professor Revanti, who is at the back. She's just waving right now, so whoever is doing the stewardship, please follow her. And the last group, which will remain in here, is the health systems strengthening, whose moderator is Jyoti Joshi, who is right in the middle, and she will stay here with that group. So I will encourage you to go ahead and have some discussions and think through some of the questions. We have added for the questions, we want you also to reflect on the environmental dimensions and the animal sector as well. And for also, just so you know, later and today, we're actually discussing much more on the issues around animal sector and environment as well. So please bear with us. And Viviana, you had one, question or?
No, just wanted to highlight that point you were making, Mirza, that for the agricultural sector and aspects in environment on the Access Group, we hope that those discussions can also take place. So inviting also those interested in that to the Access Group.
So please stand up and go to your groups. You will be there until 11:10, I will say, and then you can take your tea break. We'll be back in this room at 11:30 with the next session. And thank you very much, everyone, today. Everyone today for attending this morning session, and thank you very much to our panelists.
Greetings. My name is Dr.
Announcement, interpretation is only available in this room. So anyone who needs interpretation will need to stay. And then also for the people staying here, we'll encourage you to please come forward because then we will move the chairs and then just have here at the front so that we can have the
is one of the major threats that we face in this age. It claims millions of lives. It threatens the achievement of many sustainable development goals. Just the recent report, the Graham report, shows us that there was a great death rate of about 1.4 million people died in 2019 attributed to antibiotic resistance. And out of those, 225,000 people died in the African region. We know that Africa has got the largest burden of infectious diseases. Africa has many challenges: lack of running and safe water, a lack of access to common antibiotics. There is overuse of antibiotics in both the human sector and the animal sector. ReAct was established to be this organization that will catalyze action and bring this issue to national, regional, and the global front, that antibiotic resistance is an issue we should be dealing with and that needed immediate action. We've been supporting countries develop their national action plans and we have supported, Africa CDC, WHO Afro, OIE, FAO, and UNEP in really establishing some antimicrobial.
Hi, everyone. Can we have all those who are in the group on the health system strengthening to please come forward in the front rows? We can even move chairs and make a circle in the front because that will aid our discussion. So all group participants for the health system strengthening, please move forward. Thank you.
Also on the and even the environment. We had some very good interjections today where the speaker highlighted that we are talking only of human health loss and lives being lost, but it's livelihoods also that are equally, if not more important in a day-to-day life for a person. So keeping that in mind, I think I will open the floor. I would like to introduce myself. I'm Jyoti Joshi, and our rapporteur is Judith. Judith, will you just wave for us? And she will be taking the notes for our discussion, which we will present at the end. So maybe I will just open the floor for all of you to suggest, first of all, what have been the challenges or the things that you feel have been barriers for including these different sensitive, AMR sensitive aspects of IPC, WASH, vaccines in human or animal health, which must be included if AMR has to be tackled as a problem. So who wants to start? Oh, you can't hear this?
Great. I'm sorry for that, especially to our French listeners. So the idea of this session, I'll just quickly recap, is to get feedback from this group on what can go to the high-level meeting in 2024 on what are the aspects for AMR, addressing AMR through other interventions like water hygiene, sanitation, or infection prevention, vaccines, which are preventive measures rather than just looking at treatment and cure as or looking where antibiotics are used to tackle the AMR as a programmatic approach by countries. And this, the other complexity we must clear is it's not just human health, but also animal health, environment, and other sectors. So we can start by discussing what have been the challenges in looking at the value of these interventions to tackle AMR, and how can these challenges be overcome if we now address this next version of tackling AMR programs as a program now in the next version at the UN high level. What would you like to see that you have not seen so far? Please. And I think use your mic so it will help speakers.
Okay, I think I'll be straightforward. What I'd like to see from especially the human health and the animal health is the identification of these, I don't know whether you call them bacteria or antimicrobials that can be included in the water quality or in the effluent, in the effluent monitoring guidelines, so that with these parameters coming out very clear from the human health and the animal health, it guides the enforcement agencies it guides the other actors. For example, we had a discussion in the yesterday about the interconnectedness of these sectors in the One Health approach. You find like the agri systems might be using irrigation, the irrigation might be using pesticides, and the animals may also want to drink from the same water. So what are these guidelines? What are these bacteria? What are these antimicrobials that we want included in these parameters? Once it comes from the WHO, it becomes actually quite easy for UNEP to support, or maybe environmental agencies to implement. Otherwise, if it starts from the bottom up, it will look as if when you include ampicillin as one of the indicators, it will be viewed as the health sector that we are fighting a given molecule. So that once that is set out clearly, the IPC model, especially in the monitoring, surveillance, and implementation, will actually become easier for the other sectors. Thank you.
Thank you so much. So if I can paraphrase, because the UN high-level meeting is also not just WHO. We will have all the quadripartite agencies. So if I've understood your point correctly, we should have indicators for monitoring, some AMR sensitive indicators for monitoring in each aspect of whether it's environment or agriculture, for where the antibiotics are getting used, or some bacterial indicators for measuring the transmission or the generation of resistance. Is that right?
Yeah, if I may make it simpler, standards.
Standards, yes. So maybe, and that is for all sectors, you are saying, not just the health sector that we must have these for.
Okay, where I was about the health sector, they're the specialists in this area. Yeah, they can.
So they should lead and support the growth.
Yeah,
perfect. I think we've got that. Any other comments? Yes, I see a hand at the back.
Thank you. So my name is Randolph. I think what I would suggest here is to scrutiny policies that govern RPC and that of WASH, because these are if the policy are not scrutinized, you know that there will be increase in antimicrobial resistance in the country. So I think all countries have this policy. What we need to do is to just scrutinize them, make them more visible to the people, and at the end of the day, people will not be rushing towards antimicrobials. That's my take. Scrutiny more people and having their knowledge be done. Thank you.
Thank you. Judith, do you have that?
Yeah.
Great. So sharing those experiences between countries and people is, I think, is what I have understood from the distance, right?
Yes, so we have to scrutinize the policy that got the RPC measures in the country, because if we scrutinize them, make them more visible to the people, they will have reduction in antimicrobial usage.
Yes, thank you. And I think I see two more hands here, and I would encourage all of you to think. We've had some comments I have received earlier, which I find echo very well with me, is we are always tracking the drugs and the bugs, but we are not looking at people and the impact of all that we are talking in AMR, how it mainstreams into country priorities, because countries work through these vertical programs, or budgets are sanctioned across it. So what can we incorporate about AMR within these existing priorities will be helpful for ministers and technocrats to monitor and come back and say, yes, we are doing something. So I see hands first at the back. Yes, a gentleman in front, and then I will come to the front.
Okay, thank you for the discussion. Basically, I always see that community engagement could be a first thing that we can always think about, because you realize that these antibiotics are taken by these. Actually, they are the potential users of the antibiotics, the natives. So if these natives are not taught on when and how to apply antibiotics, basically we will be beating around the bush, because even if you train the health workers, still these people, the ones that are going to take the antibiotics, are not aware of how, of when and how they can take them. So I think it should be a poll, like everyone in the community should have an effort they have to put. So actually, we should have all those factors that come into play so that we can have a strengthened healthcare system. Thank you. Yes, sure.
So community engagement or people engagement has been a challenge, and that's something that we must tackle. I have one gentleman at the back, and then I'll come to the front row.
Yeah, I think that in most of the situations, when the physicians or the veterinarians who are forced to use the broad spectrum antibiotics, when the diagnosis is not proper, they are not sure about the diagnosis. So many times for viral diseases, especially for respiratory diseases, viral respiratory diseases, antibiotics have been misused. And in many cases, in the livestock management, these antibiotics has been misused for minor symptoms. So it has been taken as a polypharmacy type of approach. So what the physicians are in a manner forced to do that because there is a delay of treatment diagnosis and they can't wait with this for treatment, especially in the middle and low income countries. When the people are approaching for a physician, they can't wait for 2-3 days, leaving their livelihood. So they end up with, if the physician is not giving them antibiotics, they want to suppress the symptoms as early as possible. So eventually they end up with some quacks who are giving antibiotics in the first visit itself. So we should devise some diagnostic assistance devices or models, especially now where AI and radio diagnosis has improved. So it has speeded up the diagnosis, whether we can segregate whether the case is a viral disease or a bacterial disease. So this antibiotic is required for sure, or a broad spectrum antibiotic is required for sure. So that will reduce the misuse or overuse of antimicrobial drugs, and we can mitigate AMR also.
Thank you. So use of diagnostics and digital innovations, like I think AI is what you mentioned. So those we should speed up. We haven't done so far in AMR. Thank you for that point. I can come to the front row. I start with the lady here, please.
This feels very formal. I think something at the sort of systems level that we should be advocating for is more investment in community health workers. I think our colleague here said community engagement, but at a systems level, how do we engage that workforce that's there, but that's often underutilized and kind of marginalized within the health system to explain to patients about antibiotic use and you know why they have to follow the full course and all those other things that doctors, especially in rural and resource constrained settings, don't have the time to actually dedicate to their patients. So I think at a systems level, that kind of investment in the community health worker force would be something that could play a huge role, not only in AMR, but across the kind of different health issues that are being faced in the region.
Oh, okay. So thank you. I'm going to speak from a prevention point of view. I'm from the environment sector. So I'll give you an example of what we are advocating for in my country. I'm from Zimbabwe. In our new NAP 2.0, we are advocating that on the objective on infection prevention and control, we have added in also and pollution control. So on this part, we are also going to include issues to do with waste management, be it solid waste, liquid waste issues, water quality issues. So that part on pollution prevention would look at all the aspects that are to do with the environment and thereby looking at a prevention of diseases and thereby also, basically looking at strengthening the health system by preventing the diseases. Thank you.
Thank you so much. That adds to the One Health perspective we are talking about today. Can we have you?
Good morning, everyone. My name is Yohai. Just quickly going to, I think I mentioned this yesterday and I want to mention it again because I do feel like it needs to be emphasized until it gets out there. It's like there is a gap in between the community level versus the up here, what is going on up here, the spearheaders of AMR activities. And I mentioned yesterday that on the ground, for example, the province where I come from, which is 80% rural, we tried to come up with youth initiatives to reach out to the most typical places in our local languages. And when we walked into government offices to introduce the initiatives, it took us quite a number of days to make them understand what AMR is and why it's important for them to come through and support it. And that was very difficult because at some point they had to refer us to the Ministry of Health because they felt Ministry of Health will understand better. So there needs to be a decentralized kind of approach whereby you bring it down, first of all, to the government offices in the local places, make them understand the importance and urgency of the matter. Then from there, these local offices will be able to reach down to the community level, and at the community level, they'll reach down to the youth and the vulnerable communities. So this gap needs to be bridged.
Thank you so much. And I will hold on to this thought because after like another 10 minutes, we would like to wrap this to go to the second round, which was, this is about challenges, but we also need solutions that we would recommend that the high level meeting encourage or support. So I think we must go back to that discussion after we have discussed the challenges so far. And then finally, the third part would be about how the external environment, the donors, the funding community can support that change here in Africa. So let's continue with our challenges discussion first. Did you have a point? And then I have two online questions, points also. Okay, you and then online.
If I talk about IPC in healthcare facilities, I think the challenge is how to convince the healthcare workers about the importance of implementation of IPC measures. Actually, the difficulty is changing the behavior. This is the challenge. How to change the behavior. I think the answer, okay, or the solution is to, from the IPC perspective, is to adopt the multimodal strategy provision of resources and facilities, training, education, observation, and giving feedback, reminders, and finally to reach the target which is changing the behavior. Why not to set a key performance indicator, IPC KPI in AMR program? I think the importance to set, for example, the compliance of hand hygiene in the healthcare facility as one of the KPIs in the facility regarding the AMR program in the healthcare facilities.
Thank you.
Thank you. My name is Stella. I'm from Uganda, though I'm labeled United Kingdom because I'm doing a PhD at Oxford. So my biggest challenge is integration. My PhD, I'm looking at the national action plans from Sub-Saharan Africa. So I'm reading up to 30 NAPs word per word. And what I'm looking at is medicine quality. So where I'm thinking integration is a challenge, we all know it's a drive of substandard and falsified medicines are a drive of antimicrobial resistance. But because we have not integrated them at the top level, it's lost at the bottom level. Look at the previously published 40 priorities for WHO, the research priorities. There's no medicine quality anywhere, but it is a known driver. It is documented. So the integration, when it fails up at the systems level, even at country level, when I'm reading the NAPs, most introductions, when they're talking about optimizing use, they talk about substandard and falsified medicines as a big challenge in the country and a drive of AMR. But when you go to the interventions, there's no intervention that addresses medicine quality in most of these NAPs. So we really need to work on how we are going to integrate some of these things into the existing interventions that we're implementing at country level. Thank you.
Thank you.
I think for me, I'll take, we are talking IPC, and that's infection prevention and control. And the basics that we look at is just dealing with hygiene. I think we need to have programs that incorporate at different levels. If we are going to deal with the school-going children, we need to just encourage the hand washing and all those things. Why are we doing that? Because it is cheaper to prevent than to get into what we are doing. Apart from that, we are not looking at the basic standards. For example, those who are in practice, doctors, I think when they find the basic standards infrastructure, that helps them to really run and prevent and do their work. If those basic standards are not there, infrastructure, water, running water, and all those things in a facility, I think becomes difficult. It's high time we begin to push more for all those basic standards at healthcare, in care facilities to be there. I think that's when we can deal with IPC, for example. And then it also helps us to even prevent healthily acquired infections. All those are coming because the basic standards sometimes are just not there. We can say we change the behaviors of doctors or practitioners in whatever form, but if you don't have those basic standards, what are we going to get? So I think for me is we begin to look to lobby government, advocate for whatever facility we are going to build or put across, we need to have those basic standards. Thanks.
Thank you so much. And I think it's been nice hearing all the discussions on the challenges as we move to the part about solutions. And what I would just, before I pass on to the online comments, because I think we've got a lot of solutions coming up in the online comments that we have, is I would just like to summarize all of our discussion and say, in a sense, when we are talking of preparedness of the health system for tackling antimicrobial resistance or stewardship, we need to incorporate all these indicators, whether it's community engagement, IPC, wash standards, or availability of like running water or a toilet, into some kind of tertiary indicator or score, which it is never about these basic indicators that hand hygiene was maintained, running water is available. So maybe having an indicator that merges 2 or 3 of these basic elements of IPC wash, and we haven't here had comments on vaccination, but a speaker yesterday spoke very nicely about rotavirus vaccine, eliminating the need for care or health seeking for many. Don't measure that, or we don't have a research to policy effect being indicated that shows that if the basic systems of prevention for AMR are in place, a lot of the burden of AMR is tackled.
sector, the WHO will be publishing the people-centered approach to AMR to guide countries to have a comprehensive approach that's people-centered. This core package of interventions includes interventions specifically on resilient supply chain of quality-assured health products, including actions to mitigate safe antimicrobials. Thank you.
Thank you for the comments. I hope the online people can be able to hear that their comments, maybe you can just type it for them that their comments have been shared. And many of them are what we have discussed. And I think that brings us back while we were discussing the solutions more for the health sector to the point that was raised about quality of antimicrobials and standards in the environment and agriculture. So that brings us back now to solutions in these sectors like we have discussed. We should discuss solutions. So I see a hand raised and I would request you to speak up, please.
Hi, thank you. So I have a couple of ideas. Also linking into the first question you had is we should really think part of the behavior change is delinking AMR from human health. Zimbabwe has the best model I've seen so far where they've got a One Health office from each of the departments, which seems to sit under the presidency. Because as we all know, AMR is so the mitigation of AMR depends on a lot of inputs from a lot of departments. I've made a couple of notes of the departments in South Africa, for example, that will be affected. For example, the Department of Infrastructure, like how are hospitals doing with wash basins? The Department of Water and Sanitation, do we actually have clean water? Forestry, Fishery and the Environment, so the effluent, and the Department of Basic Education. What about our Department of Communications? So if human health, which is the Department of Health, is always pushing the mandate, pushing the agenda, it's going to be difficult to mandate these other departments to do this. So if we can get the presidencies to actually consider delinking AMR and kind of sitting it under like something similar to the IHR, International Health Regulations, which sits under presidency, we might have a way forward. Also regarding kind of continuation of funding for surveillance, because we also struggle with continuation of funds, because you get a grant here, you get a grant there, and you're always struggling for this. But we need to, somebody mentioned today as well about sustainability. So in pre-regulation of antibiotics with regulatory authorities, why can't we just say with the pharmaceutical companies that maybe let's work together, you put some funding towards surveillance of your medications. There's also continued registration requirements of the antibiotics. So how is your surveillance doing with your drug after about 5 years, whatever. And then they can put their money into surveillance in the environment, surveillance in animal health. We can have one great dashboard for the country, because pharmaceutical companies also sell antibiotics to the animal sectors, environmental sectors, and health sectors. So we can bring them on, support us there as well.
Thank you. I think those are very critical comments, and I hope, Judith, we have them, because the high-level meeting is about political commitment, and like you mentioned, the Zimbabwe plan, and where we are seeing AMR plans need different sectors to work together. So this high-level commitment will be valuable input at meeting. And second, you mentioned about the different stakeholder government systems job. It's about
which will correctly diagnose most of the respiratory diseases, including pneumonia and all, where most of the misuse is happening for viral pneumonia and all those things. And then we can facilitate for the adherence of the drugs. Not prescribing the drugs or limiting the drugs is equally important for adherence of the drugs once it is prescribed. So not taking the enough dose or breaking the drugs in between also creates antimicrobial resistance. So we can make a policy that the physician or the agency from where the drugs has been issued have a responsibility for tracking the adherence. So for that extra human resources, or we can use technology also for tracking. There are a lot of technologies already available. Whenever the patient is taking the medicine, we can keep it in a box, and the box is open. We get the information that patient is taking. So like things, or we can send the community workers to the home and monitor whether he's or she is taking. So facilitating the adherence should be the responsibility of the person who is prescribing the antibiotics. That is one thing. And drug quality and standardization that have to be done in policy and legal level, that have to be also done. And last but not least, the research and development, investing in R&D for developing of newer vaccines have to be also incorporated as our remedies for all those challenges. Thank you.
Thank you. So I think you've given us a lot of recommendations, and Judith, I hope you have captured. Some will be R&D related, like you said, for investing in vaccines or diagnostics, which are digital or others. The other was on adherence, which could be the prescriber or even the company, again, through a process. But adherence and knowledge of how the antibiotic is being used and not misused, so that it's appropriate use, is something that we can create mechanisms for, is what you're indicating. Yeah. So we will take those solutions. I have the gentleman at the back, and then I will come to the back and then to the front, please.
Okay. The first one is to design or come up with appropriate waste and wastewater treatment technology that are appropriate to handling antimicrobials. Yeah, because what we have at the moment in Africa cannot handle antimicrobials. The second one is develop guidelines on the use of hormones or antimicrobials in aquaculture. I don't know how that is being done at the moment, so we need guidelines on how to use these hormones and antimicrobials in aquaculture. And then we also need guidelines that can help during the environmental impact assessment or environmental audit reviews, and also providing of mitigation measures. For example, if you're constructing a pharmaceutical company, we identify, or if there is a pollutant, what are the checklists that one can, these guidelines should actually help us to come up with checklists on what to look on every specific projects that I have that contributes to antimicrobials. Lastly, we need standards, universal standards on laboratory procedures for sample collection and analysis of antimicrobials in environmental matrices. If our rapporteur has not captured, I can be able to type them and share them with her, but largely these are my solutions. Thank you.
Thank you. I think that's very helpful, and she would have that. Otherwise, we will connect with you. And if you permit, one aspect, I think, from the talk we had from Dr. Sujit today was developing those standards, but also piloting the implementation so that, the policies are informed by practical experience and understanding the mechanisms of how that can be incorporated into existing structures, like you mentioned, the environmental impact assessment, audits, etc. Is that fine if we add some pilot aspect to it? Yeah. Thank you so much.
Yeah, that's okay. Thank you.
So my name is Randolph again. I think scripting public system is not only relying on only health practitioners, I think we have to get the journalists to involve. We as health practitioner or the government have to train journalists, at least if they sit on their various media station, they'll be able to raise awareness to all RPC and WASH measures. And also one of the things we have to do is also to invest in youth capacity building. I come from a country, Liberia, where we have almost 6 million people, and 65% of this population is made out of young people below the age of 35. And Africa too has a larger population when it comes to young people. So if we can invest in young people capacity building, they can be the one to channel this information in our community, in our schools, and in our various churches. And one of the things we have to also do is that, well, I think one of my colleagues spoke about youth capacity building, bridging the gap between government and that of the youth center. I think this is why one of the things we have to do, because we are young people who have the energy to work, and the government has to recognize us that this is these young people have the energy. We have to invest in them in order to have the work done better. And one thing I capture that we also have to take into consideration is health promotional. Health promotional is also one of the things. I think one of my professor or doctor mentioned it from FAO. He said that it will have primary health information be given out to the community. There will be reduction in the usage of MR. I think this is where I will stop. And thank you so much for the opportunity.
Thank you. I think those points are well taken. So having some indicators or benchmarks for the high level to monitor the preparedness for AMR and health system strengthening beyond just the 4 sectors we have for AMR, like youth's involvement or community engagement, etc., could be valuable suggestions. So thank you for that. I can now move to the front, please.
Yes, good morning. Thank you for the chance. I also concur with the use of health promotion and sanitation, as this will prevent the need of the use of antibiotic. But also we have many interventions at the upper level. Let's say at national level, we have a so-called technical working group and the MCC, but that is only remain at the higher level national. So we need to cascade that or decentralize to the lower level, so that whatever it is happening in the higher level is reflected down to the lower level. But we also have to strengthen the AMS team, antimicrobial stewardship team. We can make that as standalone, but we can also integrate the system existing within the facility. That will aid the healthcare workers to work as a team, so that they can use the proper antibiotic when there is a need. But also, I see the many research support that the use of antibiotic commonly happen to the private facilities, and most of the intervention do happen to the government facilities. So there is a need to reach those private facilities, whether it is health facilities or community medicine outlet. Those dispensers should be alert, should be capacitated to the level of understanding the impact of the antimicrobial use. Then at the end of the day, we have to strengthen, of course, no citizen will get antimicrobial or antibiotic on its own. He or she has to get it from either medical outlet or from the hospital. So there is a need of strengthening or capacitate those prescribers and dispensers to give the proper instruction, like take the full course. Don't share the dose with someone and the like. Thank you.
Thank you. Those are very valuable inputs. Judith, you would like to contribute, yeah? Okay, so just before I summarize your points, one is about empowering the AMS teams at the facility. So this could be fed into the governance systems, and so that they have authority and rules to monitor antimicrobial use. And also not just the formal networks you are saying, even the informal networks or pharmacies where antibiotics are distributed should be part of the network for understanding the antibiotic use patterns and monitoring AMR overall, right? So we have those points. Can I go to the neighbors? Yeah, the lady here. And then I will come to the front row after that.
Merci. Moi, je vais parler en français. Ok, ça marche. En fait, je suis dans la santé humaine. Je viens de Madagascar. Je suis Manuela Christopher. En fait, nous voulons promouvoir des directives thérapeutiques améliorées et évolutives, surtout pour les praticiens, les médecines libérales qui fait son travail dans les bourses, parce que là, dans les
I can try. Okay.
It's okay. Ok, merci. En fait, je répète un peu ce que je viens de dire. Donc, il faut promouvoir des directives thérapeutiques améliorées, évolutives pour les médecins pratiquants, les médecins libéraux dans les zones régulées et dans les zones rurales, et aussi les programmes de PCI soient effectifs aussi dans ces formations sanitaires dans les zones rurales et dans les zones éloignées. Yeah. Ok. Je continue? Ah, ok, je continue. En plus de PCI effectives dans les zones reculées, il faut aussi faire contribuer les secteurs privés, les pharmacies privées, les dépôts de médicaments avec le ministère de la Santé pour le suivi et les collectes de données sur les médicaments qui sont vendus dans les pharmacies libérales. Voilà en tout ce que nous vous proposons. Merci.
Thank you. That's a very valuable point. In fact, 2 points I have taken. One, private sector involvement, which must be always inclusive at a country level, and also the pharmacies, not just hospitals when we are talking of AMR. So we will keep this in the solutions, but probably you could think back and tell us how. Like, would you want it at the governance level, province in the structures, or in a technical element? Maybe that's some food for thought for all of us for the next level. Yeah. So I go to the next speaker on your row, and then I have to move to the front. I will come back to you later, sir.
Thank you very much. Good morning, everyone. My contribution is about health system strengthening. So health system strengthening is basically about equity, quality, and behavior, and resource administration, and also a better health outcome. So health system consists of people, institutions, resources, activities to promote and to also restore and maintain the health system. So the current trend which is happening in the society, which we have practiced or which we have been encountered as a problem, is AMR resistance due to the OTC, over the drug counter, OTC. So what normally happening in the OTC is due to the lack of guidance by the healthcare provider or competency level, which also part of the challenge. Also, frequency, duration, and dosage of the microbials, which has been consuming by the patients, by the clients. And those are mostly amoxicillin, macrolides, cephalosporins, tetracyclines, which has been taken by the patients, and 50% of this threat is there. And nowadays, the global threat is antimicrobial resistance, death, which is linked globally, and this is the WHO biggest threat of the World Health Organization. So the contribution is the OTC use of antimicrobials, which can be also monitored by introduction of a kind of policy, assessment, or evaluation. Then also improved health service delivery in terms of development of infrastructure. Also a health workforce expansion in terms of delivering a quality healthcare, competence-based. Then improvement of HMIS, health management information systems, also access to established medicines or access to the basic medications to the community level and all the health sectors, all the level of the healthcare delivery. And also financing to the health systems and leaderships and governance, which is also an important role in the developing of AMR policy and surveillance and monitoring. Thank you, Chair.
Thank you. I think you've touched on a lot of points and Judith has them, but specifically I will highlight what you have talked about, the competency-based training. And we had this session yesterday from Pascal where she showed that only 1% of labs are being, 1% of the infections are being tested. So laboratory preparedness, human workforce, and other aspects are touched, as well as tracking over-the-counter antibiotic use and policies probably that we can pilot for it, because I think that is the cat in the bag that we have to try and catch so that it is not, it reflects the realities of life today when access to antibiotics is needed. It's not hindered, but at the same time, inappropriate use, which is actually unethical and can have adverse consequences globally for public health, is also looked at. So some pilot strategies for that would be very useful. Thank you for that. I can now move to the front. I think I have Judith waiting first, sir, and then I will come back to you.
Finally. So I have a few points and I will start with the medicine quality. I think the one who raised the medicine quality, it was really a good point, considering the circulation of the substandard in the market. So as much as we are looking at enforcing regulation and stuff, what else can we do, even at the facility level where the drugs are actually supplied and used? So one of the things we are doing in my organization is we are trying to equip healthcare workers with some of the checklists that really guides them on the visual inspection. So as they're receiving drugs from the suppliers, what are some of the important things that they need to check on? So it's also married to what the lady, sorry, I don't know your name, in terms of capacity building healthcare workers. So as much as we're capacity building, healthcare workers around the AMR, let us also not leave out the component of supply chain management, because it's really, really important. And it also responds to aspects of, stock out, having that minimal consumption within the facility. Another point I have is from the policy level is having a standardized way of information sharing. Because at the end of the day, and I think I said this point yesterday and I'll keep on insisting, is that when the government is presenting data, do they incorporate data from the private? So what measures do we have in place to actually be able to collect data from the private and also the church health facility? So having that standard information sharing mechanism will be really important so that we can be able to present a true reflection of the country.
Thank you. Judith, you will have your points. And I think they are very good because they are solutions oriented, even if it's a physical check for the quality of the drug and just inventory management for stockouts. At least it's a start in linking solutions and health systems for tackling where we are in the situation for AMR. We saw from Pascal's presentation that we had almost 80% drugs which are access category here in Africa and very little in the reserve, which is good so far. But if you get reserve drugs because people need them, and if we can't track the availability, the cost, and the effect on the resistance pattern, then again, we will be running out of, we'll be developing resistance to them and running out for their use. So I think that ties in with what you said. I'll move to the gentleman at the back here first, and then I will come back to you, sir. Yes, please.
Thank you. I'll be brief. My thought from the contributions we're getting is we've been on this for 10 years now. The Global Action Plan was started around 2012. And we've developed so much material at the global level and some material at the regional level. What we have not seen develop very well is, and I think she talked about it when we talked about leveraging political high-level support, is that we have these products up there, including political support, but it doesn't get down to the country and to the facility level. A good example is the UNGA 2016 declaration. That was a commitment by all heads of states to do something about AMR. They said, we commit to do something about AMR. And what we see now, 7 years later, is countries are looking for resources. And when they talk about local resources, they say governments don't have, and it's not a priority. So what we need to do, and I think as a very simple action point, is to leverage, to capacity build on leveraging available resources, including commitments, because if we structure our support from the global level to the countries, to hold accountable our leadership, because our president said we'll do something about AMR. That's a huge commitment. We can get $100,000 from that and do something about IPC on the ground. And so we need to do better, I think, in the 2.0, the next 5 years, to ensure that whatever we have at the global level is passed down and capacities are built to leverage those. Because we might be recreating solutions. I can tell you, for instance, in the environment, we have enough standards and priorities for what he was requesting for, but most of them are not passed on to the countries. The Codex has developed, for instance, SOPs that can cover some of these. IPPC has got standards on antimicrobial use in crops, but they are not seen when they come down to the country and the local level. Yeah, thanks.
Thank you for those comments. And that weaves very nicely into the third component that we must discuss about what can the international community do to support the efforts at the continent level and country level, and how that can be taken to the high level meeting. So what, if I start with what you said, bringing in accountability for the commitments that are done, let's say at 2024, not just at the national level, but probably below or even at facility levels to some extent, if that can be linked in with the country's own commitment to up its own expenditure to develop their own health systems, which is then supported by development partners to, gather data for evidence that we discussed for policies, or to pilot policies that we know can work, like the solutions we have just heard from Judith about strengthening the logistics supply chain for drugs. So I think that is one feedback we can definitely take as solutions for what the international health community could do. But I would welcome further ideas now on how this can be done for health system strengthening for health, but also One Health overall. I see the gentleman at the back. We can start there, and then I'll come to you, sir. Sorry, I missed.
Okay, sorry, I just have to make a clarification on what you just mentioned about the idea of the Codex. Codex deals with the residue levels on the product. But what I was asking earlier was about we need indicators specific in environmental matrices, in water, in effluent, in soil. This actually presents a challenge because what has been developed are actually product specific, which cannot be applied to monitoring in the environment. So that's actually the clarification I wanted to see. And also when it comes to laboratory analysis, The challenge comes on the environmental sector when we are taxed. What are the contribution of data that we come once after we've done analysis of this parameter of these samples? What are the indicators that we're looking at? Because our indicators are basically E. coli, the general coliform, which cannot contribute to data on these antimicrobials. The last point I want to mention is about we need waste management methods and or return back schemes for the community or the users at the household level. Because I personally, sometimes I don't exhaust all the drugs and I'm left with them. So what can I do? Because we had this discussion in Kenya, like if we return these things to the local pharmacy because of the nature of this, let me just use lack of trust or maybe inappropriate method, this can actually be repackaged and find themselves again back into the market system. So how can we have a reliable waste management or return back schemes to be able to deal with the expired drugs or unused doses of antimicrobials, at the community level so that we don't have this just drain down the sink or into the system. Thank you.
Sure, your point is well taken. So standards for actual wastewater treatment facilities and recall mechanisms for the unused antibiotics so that they're disposed appropriately rather than into the wastewater, and likewise. So we'll keep that as in mind. That takes me to the person at the back, and then I'll come in front, please.
Yeah, thank you for the opportunity. And I just want to reinforce what has been said about the integration. So, AMR, as we've already seen, it's a health system issue. And I think it's very important that we try as much as possible and leverage on universal health coverage. And this because I feel universal health coverage has a lot of political buy-in. Because one of the things that we need to realize is that also allocation of resources kind of aligns with a lot of political buy-in, which is influenced by what the politicians are able to sell to the public. What would make me be re-elected next time, So I feel it's very important. And this because universal health coverage covers a very critical aspect of healthcare financing. And one of the reasons why we have a lot of difficulty in terms of behavior change, especially in communities, is because of poor healthcare financing mechanisms where people have to use out of pocket. And so, it becomes easier to actually go to a chemist instead of going to a hospital, because apart from the cost associated with transport and everything, maybe I have to pay and go and pay for some consultation fee, pay for some laboratory testing and the rest. So why don't I just go to the pharmacy and obtain the drug? So a lot of our the behavior implications are actually influenced by the health systems and a lot of healthcare financing. So I think this is something that we need to try as much as possible and find a very good linkage between antimicrobial resistance and universal health coverage. And this is because I've seen politicians warm up to universal health coverage more. So let's see how we can interlink the same. Thank you.
Thank you. That's an excellent point, because from the experience we have from some countries, even the lab testing is not included in the packages that are, where medicine is provided free of cost for certain categories. So if even that stewardship, diagnostic stewardship can be incorporated and then appropriate prescription include, it can be a game changer for AMR. So universal health coverage is definitely, I see political commitment, like you mentioned, post-COVID especially. So that's something we must capitalize on and have indicators for AMR in the UHC agenda so that we can see progress and investment being made by countries and healthcare community. So thank you. That's a very valid point. Judith, I hope you have it. Yeah, so we can move in the front. Yes, Ruth, please.
Thank you. So this is more higher level, and it's on surveillance, which actually isn't one of my strong points. But I know the animal has a kind of version of GLASS where you can submit data on antibiotic use all the way down to species, etc. I'm not sure if environment has anything similar to that for like a country collaborating surveillance dashboard or database. So that would be something nice to see, because the countries like to brag that we're a member of GLASS, and it really motivates us to want to look at our own systems and improve, especially when we see other countries. So it's a great talking point and learning point between countries, I think. And then I think we also, because I think the question is also about how we ask organizations to support us. So we would really need support in interdepartmental communication and collaboration, because I know that I struggle to talk to the veterinary people, and I don't know how I'm going to speak to water surveillance specialists. And then a second point is we would also need support and collaboration, communication between inter-country collaborations. Like, for example, I'm just seeing in my mind that with environmental and waterways, the waterways pass through borders, and we might be interested in maybe South Africa is doing something in a waterway that then goes to Zimbabwe, or the other way around. I'm not sure which way the water flows. So we would need somebody who's outside the political area who can kind of move a little bit more freely and help us like engage with each other and see what we need to map. And then maybe we can even have like a physical mapping between the countries where are hotspots. And then in that mapping, we can link in human surveillance and agricultural animal surveillance, both for antimicrobial resistance and antimicrobial use. So that's just kind of a long-term idea.
Thank you. Those are all very valuable. Support from the international community to encourage interdepartmental and inter-country research and policy ideas that can be piloted for tackling AMR and strengthening health systems overall, right? If I can summarize as that, Ruth. So thank you for that. We have 10 more minutes, and I think we need solutions for all the problems that we have discussed. So ideas, everyone, especially for the community engagement and the IPC component. Yes, sir, please.
Ouais, je vais parler en français. Ouais, je crois que nous savons tous que la meilleure façon de combattre les résistances aux antimicrobiens, c'est l'approche intégrée qui est pratiquement l'intervention de tous les secteurs dans l'approche One Health. Mais ce que nous sommes en train de remarquer sur le terrain, c'est que le secteur de la santé humaine reste pratiquement le seul secteur qui se bat avec des indicateurs qui sont objectivement vérifiables, et que les autres secteurs ne restent que dans le sens, au niveau pratiquement de la théorie. Et ce qui est plus important ici, c'est que nous devons être à mesure de construire ou d'élaborer des indicateurs qui sont objectivement vérifiables, qui vont prouver l'intervention de chacun dans cette approche One Health. Et de l'autre côté, nous savons aussi que au niveau communautaire, de manière générale, ce qui est plus important, c'est le changement de comportement. Nous pouvons bien investir des millions au niveau national, mais au niveau communautaire, s'il n'y a pas de changement de comportement, tous nos efforts sont voués à l'échec. Donc, nous devons beaucoup considérer le changement de comportement au travers des campagnes, n'est-ce pas, des sensibilisations qui doivent continuer. Et je sais que les efforts au niveau international ne sont pas à questionner maintenant, parce qu'il y a déjà des efforts qui sont visibles. Ce qui reste, c'est plutôt au niveau communautaire, là où les comportements n'ont pas encore changé jusqu'à maintenant. Et je crois que beaucoup d'efforts doivent être consentis à ce niveau-là. Merci.
So thank you for those valuable comments. Verifiable indicators for other sectors. I think we touched about environment, and we should have similar for animal sector or others, like you mentioned. And then the behavior change. aspect is a problem we have all touched on. Probably we need solutions that need to be piloted, and because it's very context specific, or what drives behaviors for antibiotic use. And maybe that's an area where the international community can work with the countries to pilot different approaches for community engagement, youth engagement, like we have talked. And when the message becomes simple and easy for people to understand, that's when the job for AMR is taken to the grassroots. Very valuable points. Thank you, sir. I think we had one comment there, and probably I will wrap, and we have one at the back. And I would also encourage you, this is the last 5 minutes that we have, for any critical feedback that you would like the high-level meeting of ministers and presidents to think of for AMR. Maybe one-word answers, we can take 2 or 3 before we go to the gentleman there, and we come to you, Renier, next.
So I'll take 30 seconds. At the FAO, leveraging, I read one of the challenges in terms of community engagement and bringing this down to the community. We developed an approach called the Farmer Field Schools in rice farming in 1983. This was a community-based approach to solutions then, and we wanted the farmers themselves to decide how the solutions, what solutions they needed. And around 2018, funded through the Fleming Fund, we decided to pilot the use of farmer field schools in AMR among farmers. And we are now on Farmer Field School 2.0 for antimicrobial resistance. I think Zambia is one of the focus countries. And what we have designed now is to actually upscale in countries. We want to focus on broiler production because there's a quick turnover and a huge consumption of antimicrobials. Residues are likely to remain, and we are now trying to integrate surveillance, youth engagement, community engagement, capacity building for veterinarians. And also, like we are speaking in this meeting, we could look at health coverage and IPC and prevention in those local communities. So imagine a platform we developed for rice production 35 years ago. Appears to be a very potent community-based approach to address some of these issues. And I think my point is we have so many others, and we should look at those and see how do we leverage this to answer some of these questions. Yeah, thank you.
Thank you. I think synchronizing efforts in each sector and building on one for the other is a very valuable input. Renier, over to you.
Yes, morning. So we've been talking a lot about top-down, bottom-up community engagement, getting communities involved. So one of the things that have been used very effectively in the HIV and the TB world is community-led monitoring. So where we train community members, community leaders on these frameworks, these national action plans, so they then go out into the communities and they do the data collection and the monitoring. So this has been very well supported by Gates Foundation, USAID, PEPFAR, where they've actually in the TB environment developed tools to collect this type of data to keep governments accountable. The only challenge is that government doesn't want to listen to that type of data when it comes from the actual community themselves. So I think that is a commitment we need where civil society organizations are willing to lead on community-led monitoring, but get government to then listen to the data and act on that data.
Thank you. I think that's an excellent point, Renier. And in the case of AMR, as long as we can keep the long-term goal of decreasing the burden of drug-resistant infections, I'm sure whether it's governments or donors or community, even faith leaders, everybody is working together like we see in this meeting. So that could be a very nice way of piloting community-led monitoring with a positive spin for the benefit of the country and the communities we work on. So that's something definitely we should pilot and take to the high level. Any burning points? I see one hand raised. Anyone else? So maybe that's the last comment. We will not be able to go back for critical comments. One here. I will go to 2 here and 1 here. So we have 4 comments. Can we take them? and there's one online. So we are eating on your coffee break. So please be short and then you will get a coffee break. Otherwise you don't. Over to you, sir. And 30 seconds, please.
Thank you very much. I have a contribution on the solutions and specifically looking on how do we use the statistics that we are generating. Yesterday, we are hearing about the silent pandemic, and that is AMR killing 1.3 million people per year. Then malaria is killing 650, half of what AMR is killing. HIV, 800. Then how is it reflected to the international or global support? I see now the funds from the Global Fund. How much is it going to support AMR, which is killing more than malaria? And how much has been set for malaria? How much has been set for HIV? So I think we needed to reflect that. And another thing, I'm looking at the national action plans which have been presenting. How are we investing on monitoring and evaluation? Basically.
Sure, I get your point. If you don't mind, can we move? Using statistics for monitoring programs.
Yes, I have the last comment.
Yes.
That my friend has been talking a lot about the environmental component and the animal health sectors. Basically, they are left like orphans. We are now having initiative, for example, for IPC, infection prevention control. How much support is for public health? Then you go to animal health and environmental health, literally there are very few.
Thank you, sir. I'll have to ask you to stop, sorry.
Okay, thank you.
And I have one person in the red coat and then here, last comments, please.
Yeah, mine is very simple. High-level political commitments are good, but for us to actually translate this into implementation, it needs to be something that politicians find suitable. You know, politicians like initiatives that, you know, if I want to be elected next time, what can I do in the health sector that will actually, you know, make people see that I'm working? One of the key areas that I think we can capitalize on in terms of bringing about domestic funding is community health workers. How can we incorporate, you know, AMR as one of the critical areas of health promotion, you know, that community health workers are going to drive aboard? And I'm saying this because in Kenya, I've seen a lot of political commitment towards community health workers, because it's something that it's very easy to sell to the public, and politicians are able to showcase what they are doing in, you know, in terms of health system strengthening. So that's my point. Let's try and attune this to, you know, what politicians can actually see as a leverage for them. Thank you.
Thank you so much. We'll incorporate that point for community health worker trainings and engagement. The last comment here before we get coffee.
Okay, still on the subject of community engagement, there's a lot that's already being done at the community level by CSOs. But what we need to add is coordination of those efforts, because we have no map, we don't really know who is doing what. And if recently they launched the multi-partnership platform online, the quadripartite platform. That's at the global level, but at national and sub-regional level, we need that form of collaboration too, because people are working on the field and we need to leverage those efforts. And one last point is social media influencers. At a meeting like this one, I can see no influencers, but people really listen to them, even more than they listen to us professionals. So we need to join them, to reach out to them and give them the right information so that they could educate the population.
Sure. Thank you so much. Very valuable points, and we'll keep them. The last comments for the online people, because they have been patient with us.
So from Dr. Anya Nobuth, she says, speaking to the community engagement and how international organizations can help, it goes back to organizing educational campaigns. These can inform the public about the proper use of antibiotics, the consequences of misuse, and the importance of completing prescribed courses of treatment. Using local resources with the support of our international partners, we can engage local schools community schools, clinics, and community centers to help disseminate accurate information. Thank you.
Thank you. Thanks, everyone, for a very insightful discussion. And I think we've got some very useful points for this conference organizers to take back to the high-level meeting. If all of you have any further comments, feel free to email any of us. We are here, Tracy and the organizers, because this will be very valuable feedback that goes to the high-level meeting from this meeting here. Thank you so much and enjoy your coffee. So please take your seat.
Okay, welcome back, everyone. I will start to launch the next session of the program. I hope you enjoy the tea break and the group discussions. I was in the antibiotic stewardship group, and it was a fantastic discussion. Everybody contributed, and we're very happy with all the recommendations we came up with. Now, if we can slowly come back to your seats, and I will start with some announcements on some changes on this session. So what we're going to talk about now is the missed opportunities in AMR NAP financing in Africa. How can we increase both international funding and low and middle income countries' governments' investment in financing the AMR agenda? The way we will do this is that we have a couple of presentations to set the scene. We have some changes of the speakers because Sam, who was supposed to join us, is out working with DNDi today. He might make it, and then we'll adapt to that. So Morphin was so kind to change role from being the moderator together with me to join the panel, because here we'd really like to have an interactive discussions on how we could move forward in the field of financing. So, I mean, this topic has come back in all the discussions we've been part of since yesterday. The final words from Yuanda Alimi from Africa CDC was, Africa originated and Africa defined solutions, but also highlighting that the need of stop relying on external funding for something that is so key to our future. And when we prepared this session together with Murphy and Tracy, we said, okay, this is really the time to kind of take the next step in thinking of what can we do to address financing gaps. So we know all the challenges already and what gaps are there almost. So what can we do about it? And for ReAct, this topic has been something we have worked on for several years. We did a workshop 5 or 6 years ago called the planetary health threat, but the financing orphan, which was AMR. So, and we also addressed it in the dialogue meeting that we had in Uppsala in May, leading up to high-level meeting where financing of AMR work and a NAP implementation is key. So, but first, before we start to talk about financing and money, we'll set the scene with putting a little bit more of the geopolitical glasses on and talk about the great divide that we see in the field of the global health threat of antibiotic resistance. The higher burden of disease in lower middle income countries coupled with fewer resources to tackle the challenges. So I will invite Mark Mendelsohn,
a professor in infectious diseases and HIV medicine in Cape Town University, but also the director of Trinity Challenge. You will set the scene and give us, opportunity to step back a little bit to then re-engage in the discussion on financing. So welcome, Mark.
Well, thanks very much indeed, Anna, for the introduction, and thank you to Merfin and to ReAct and the South Centre for this invitation to speak today. Really a privilege. It's been absolutely wonderful to watch the progress of the ReAct conferences and South Centre conferences, and I really want to applaud my friend Merfin, who honestly, we are so lucky to have you to help guide us in Africa. So thank you, Merfin. So I'm going to talk to you today about the broader geopolitical issues, but it does relate to funding, because at the core of this, it relates to prioritization, and we need to understand what that is in the global south. And many of the themes that I'm going to discuss have been discussed with many people, and Merfin included, over many years. Why do I present this now? I think COVID has really magnified and brought a focus to inequity. And I think you'll see why this is an issue. My conflicts of interest are none, but I must say that although I direct the Trinity Challenge, these views are my own. They're not necessarily shared by anyone involved in the Trinity Challenge or linked to it. So just as a starting point, it's critical to once again say that AMR is the quintessential One Health problem. It is a wicked problem resistant to resolution. And clearly, all of the little elements, be it surveillance or stewardship, whatever, are important in themselves. And R&D particularly is important in itself. But the premise I'm going to talk to you about is that some are more important than others. And unfortunately, we sit at a moment in time where the world is more interested in the next pandemic than the current pandemic of AMR. And at the heart of this problem lies the fact that we have wonderful national action plans on paper, but we're not prioritizing as we should. And as a region, the global south is not prioritizing where it should be. And I believe, and others believe, that there is an elephant in the room. And that elephant in the room is that this relates to this premise. The fact is that the needs and the needs and the agendas of the global north and the global south are so separate now. They've fundamentally diverged even further after COVID, that it threatens the global mitigation of AMR. And so the problem is that leave no one behind is actually a fallacy at the moment. And I'll explain why. So the agenda of the global north, because it's gone through industrialization, its economic improvements, its ability to spend health on prevention, their needs relate to a small minority of patients who have extremely drug-resistant infections. And so cafidrocol, or the next cafidrocol, is their champion, and this is what is being presented as the need. But that doesn't bear good relation to the global south, where our burden of disease, as you know, is at least 10 times greater in terms of burden of infection, and therefore our use of antibiotics. So as the Graham report showed, if we want to change the needle, if we want to shift that needle and really make a difference in mitigating AMR in the global south, that is not going to be done by a new antibiotic for a difficult to treat resistant infection. So where is the bang for buck? Well, you won't be surprised to know that bang for buck is in infection prevention. And this is an important argument to try and give context to, because the evidence is important. Now, if you look at the global north, Herman Goosen's paper, which is shown on the graph on the left, beautifully there's a beautiful correlation between the amount of penicillin used and the amount of penicillin resistance and strep pneumonia in different.
Can you use a hand mic? Because is short.
Okay, so I'm pretty big. I'm structurally disadvantaged. I've always known it, but thank you. Can you hear me now? So basically, for each of the countries in Europe, no, me now. Sorry. Whatever you did, stopped.
Loudly.
Speak loudly.
Yeah.
Can you hear me now? Okay. I'm sorry. There are many disadvantages of being tall. I wasn't really sure that this was one of them, but there you go. So just coming back to this argument, that this issue in question. So in the global north, the more antibiotics you use on a single antibiotic bacterium level, there's a direct correlation with resistance. When in a paper by Collingham and colleagues a few years ago, that was shown that correlation vanished because you put in low middle income countries into that mix. And basically, they showed, looking at different indices, where the greatest bang for buck was. And the greatest bang for buck was in infrastructure development. So if you improved infrastructure and the elements within infrastructure, mainly related to sanitation, safe sanitation, clean water and electricity, it was that decreased antibiotic resistance or antimicrobial resistance. This shouldn't be any surprise to us. The Broad Street pump is probably the best example of how this issue of unsafe sanitation and no access to clean water spreads disease. Now, there was a second study which also gives evidence to this same issue, and that was the metagenomics study in sewage samples from across the world, where Africa, Asia, and Latin America were the highest abundance of antimicrobial resistance genes. And the element that was the most associated with that was the country's Human Development Index, the World Bank Human Development Index. Now, 3 of the top 5 Human Development Index indices relate to safe sanitation. A paper also by Nick Feasey and others, the DRUM study, a beautiful study. If you haven't seen it, I really would recommend it. In southern Malarian households showed just how much of a problem environmental contamination is and how it drives AMR resistance, this time in ESBL, E. coli and Klebsiella, which was seen not only in, as you see in the top right-hand graph, in river water, 60% of river water samples, drain water samples, but also in humans and animals. So environmental contamination is a big driver of AMR. For time, I'm going to go skip that. So we know that only half the world's population have access to safe sanitation. And we also know that 90% of those 430 million people who still practice open defecation are living in the global south. Now, just as an aside, on the other end of the scale, Murph and I have ordered you the INAX USA toilet, and that toilet is for $8,500. And as it says, literally as the lid rises and the seat heats, as you go towards the toilet, the lid opens, music plays from a sound card, and the deodorizer is turned on. So that's open defecation to the INAX toilet. But if you really want to scream inequality, then maybe the ISIS Swarovski toilet at 75,000 is for you. Anyway, we also know, as has been said a number of times here before, that we do not have basic hygiene services in our healthcare services. And there have been a number of studies trying to look at whether wash interventions did reduce diarrheal diseases. Now, these studies were actually, the diarrheal disease infection was a secondary outcome. It was mainly around growth. But there were 3 studies in Bangladesh, in Kenya, and in Zimbabwe. And only the Bangladesh showed a reduction in diarrheal diseases. Why is this important? Because the diarrheal diseases obviously drive antibiotic prescribing. So if you want to intervene with WASH, you would hope your diarrheal diseases reduce. The problem is that these studies all were focusing on household interventions, and the interventions on WASH need to be much broader. So it needs to be community-based. These were clustered in households, so it wasn't really taking a full community view of what needs to be done. Plus, in the different countries, there were different pathogens which were causing the diarrhea, which had different responses to the measures that they were trying to reduce, such as chlorination of water, etc. So those studies are variable, but there are reasons why they may not have shown a unified reduction in diarrhea. So that's WASH. WASH is a major benefit, and vaccination, of course, is too. And I'm going to go through this very quickly for a matter of time, and you'll have the slides. But there have been a number of modelling studies now. These modelling in low-middle-income countries of the effect of childhood vaccines. And this was to pneumococcus in preventing acute respiratory tract infection in childhood, and rotavirus in preventing diarrhea. And pneumococcus conferred almost 20% protection against antibiotic treated episodes for respiratory tract infection, and the rotavirus 11.4% reduction in antibiotic treated diarrhea. Under current coverage levels, the numbers of antibiotic treated illnesses prevented by pneumococcus was almost 24 million, and rotavirus 13 million. And if you could get universal target coverage, that would reduce by 40 million episodes of antibiotic treated illness. That is a lot of antibiotics from an intervention which is fairly simple. We also know that in pregnant mothers, in this study, 11 countries, given either placebo or RSV vaccine, that in the first 3 months of life, there was a dramatic reduction in antibiotic treatment episodes for respiratory tract infection in the neonates. We also know it works in adults. So in Ontario, when they went from voluntary to mandatory influenza vaccination, a drop of 64% in antibiotic treatment episodes during that influenza season. So there is absolutely no doubt that vaccination reduces antibiotic use, and in a major way. It also reduces the actual circulation of antibiotic-resistant serotypes. So pneumococcus in this systematic review and meta-regression analysis showed basically that you are reducing streptococcal resistance to penicillin and some of the other antibiotics. And those reductions were primarily driven by serotype switch. So you were taking out the main serotype. And this is true also for Salmonella typhi, and particularly in the H58 clone that is now globally being spread, 97% reduction or efficacy against XDR typhoid, which was the H58 clone in this study. And then another study by Garvey, a broader study on more countries, 73 countries again, showed a really massive benefit from vaccination in reducing antibiotic treatment episodes. So there can be little doubt in human health that vaccination is a major prevention effort that we in the Global South needs to adopt. We also, it's clear what's needed to be done. Vaccination is important in the animal health sector, and food security, as you know, is a critical issue. And the European Union have drawn up the European Commission drew up a number of different elements to interventions to increase food production and safe food production, which relate to feeding practices and housing and nutrition, etc., to reduce antibiotic use. But in the Global South, this comes, if we wanted to do similar, this comes at a time when by 2080, we are going to see dramatic reductions in our agricultural productivity, which means because of climate change, plus illegal mining has impacted on this too. So we are seeing a push towards intensification for animal protein production, which is not going to make it easy to reduce antibiotic use in food production. Also, the funding mechanism around this is going to need to be enormous. So the European Union have put 6.3 billion euros of funding earmarked to support voluntary actions against eco schemes in rural development to support only 23% of their livestock units. That's 6.3 billion for 23 livestock units. So if you're going to do this in the Global South, where is the funding going to be? We need to prioritize funding in food security towards trying to reduce antibiotic use, because as we know, antibiotic use drives antibiotic resistance in animals and potentially spill over to humans. So my argument is that the Global South's needs and goals really do, again, relate to the Sustainable Development Goals, not to the production of new antibiotics. The problem is that the funding portfolio globally is going towards North-centric research and development for new antibiotics, particularly therapeutics, for difficult to treat resistant infections seen in tertiary hospitals and in private centres, apart from obviously some outstanding other interventions like the Fleming Fund in its surveillance issues. Now, the Global North procures 60% of the pharmaceutical market, predominantly North America, but it's the Global South that is impacted by the environmental contamination from antibiotic production. And there's also an issue around API, and we'll come on to. Now, a lot of the drive for R&D has arisen from the critical priority list of pathogens in the bacterial priority pathogen list. But again, I think this smacks of some incredible iniquity, because that list was made purely on the basis of research and development financing needs. So on the left-hand column, that's what the WHO PPL, current PPL, it's being changed, but that's what the current PPL shows. If you base it on the Gram data, E. coli resistance to more than one antibiotic would be the top. But if you actually base it on public health needs, of our needs in low-middle-income countries, perhaps gonorrhea or enteric infections would be there. And if I was going to do one for South Africa, well, Falciparum artemisinin resistance actually would be far greater than ever a crab or a carbapenem-resistant Pseudomonas, which would be on my list very, very low down. So again, the drive for research and development, the targets are being dictated into a Northern Hemisphere focus. And $10.68 billion is going into research and research development. And the vast majority, as you can see from the graph in the bottom left-hand corner, in the red, but with the red bar chart, is going into basic research and therapeutics. And it's the next clopidogrel or the next beta-lactam, beta-lactamase inhibitor. Most of the money in the push incentives is going into CARB-X, 500 million, and probably another 250 million or 300 million shortly. Whereas GARD-P, which is actually much more focused on issues that are relevant to low middle income country antibiotic use, get far less. So again, an inequity. The Global South, diagnostics and vaccines, rather new antibiotic agent. Jim O'Neill's pronouncement that by 2020, everybody should be getting an antibiotic only with a diagnostic test is ridiculous. I mean, we're now in 2022 and we're nowhere near that. But we need to direct much more funding towards diagnostics and vaccines, as I've said. And there is some evidence that there's a little bit of money now starting to flow through, potentially through the GC7 fund, the COVID response mechanism, and the Global Fund have become more involved in AMR, and also the pandemic fund. Some money for developing countries. I must say, I do not appreciate developing countries as a term. I think low middle income countries is a better term. These countries that are called developing have been developed for centuries. It's not a great term. But for developing countries, 300 million for financing. And it's important that some of this is going to health systems, health resources, because we know that one of the real problems is that we just don't have the human resources available in the Global South. Again, a disparity with the Global North. And that goes for veterinarian prescribing as well. A shortage in the number of veterinarians is a threat to world food security, according to WOA and FAO. So what is the view from the Global South? This is Kailicha in Cape Town. The Global South needs workhorse antibiotics and access to them. We need syphilis treatment and rheumatic fever treatment with narrow spectrum penicillins. And we also know now from the AWARE book, WHO AWARE book, and all the work that went into it, with systematic reviews, etc., that the vast majority of antibiotics that we actually need is amoxicillin plus or minus clavulanate. But there's no point in being told that you have to use access if you don't have access. And we know that there have been shortages. Now, it's a geopolitical issue, AMR. Think about it. AMR, the active pharmaceutical ingredient, for penicillin is only made by four companies, three of which are in China. Now, if something like COVID happens again and worse, and China stops exporting active pharmaceutical ingredient, they have no penicillin globally, and that's a problem. GARDP is trying to, with partners, through its secure program, is trying to expand secure access. But at the moment, this is what the reserve antibiotics look like. They are basically totally unaffordable. So in South Africa, we needed to use cafidricol to prevent an amputation in a young girl who had leukemia. And that cafidricol for 2 weeks would have required R500,000, which is totally unaffordable. So we don't only have lack of access, we have lack of access to affordable medicines. But of course, secure will help in getting the antibiotics that we need for the very few patients, the minute percentage of patients who actually require a high-end antibiotic like cafidricol. That is not going to do anything for the global south in a programmatic sense. So if you excuse the slightly fruity language, the time has come to pull our collective fingers out. What does that look like? Well, everybody, we've heard a lot of discussion already about the UN high-level meeting in 2024, and it's an important moment in time. But if we as the Global South do not look ahead of that into the future, it's just going to be another stop event like it was in 2016. So we've got to have a longer lens. And there's a roadmap. We need governance, equity, accountability, evidence, and prioritization. And we may need targets. So we've heard a bit about the pandemic instrument, the global governance instrument, which I'm going to call WHO-CA+, which is what it's abbreviated to. And this is meant to be the instrument that AMR is going to go into in part of a broader pandemic response. But if you look at the definition of a pandemic currently in that document, this definition of a pandemic speaks to a SARS-CoV-2-like pathogen. It does not speak to AMR, to bacterial resistance. There's got to be, infecting human populations with limited or no immunity, sustained and high transmissibility person to person, overwhelming health system, severe mortality and high morbidity. Some of it is relevant, but the speed and the whole language around it suggests that it's not around AMR that they're going to be focusing on. And yes, the Global Leaders Group have defined why AMR should be part of the pandemic instrument. And yes, it is written in to some of the One Health areas, but I am wholly unconvinced that it is going to be enough and that it's going to gain the sort of traction which is going to redress the iniquity that I've described. Now, will it be enough? Well, we tried this with the SDGs. So in 2016, we went to UNGA with a whole set of asks around framing AMR around the SDG framework. And all we got was one lousy indicator, which was around bloodstream infections with MRSA and E. coli, which in itself is hospital related and not particularly useful. So of about 12 of the 17 or 14 of the 17 goals, sustainable development goals do actually relate to AMR, either in a sensitive or specific way. And we need to return to that as a focus of our interventions from the Global South. And this is what the whole of the Global South should look like, not just the UN General Assembly. Now, our main governance body, our highest governance body is the G77. And at the moment, I would respectively say there is a deafening silence coming from the G77 on AMR. If you look at who's driving the agenda for UNGA and the agenda generally, it's the G7 and the G20. Now, their priorities, particularly the G7, is not aligned to the Global South. The G7's priorities are pipeline investment and pull incentive mechanisms. Again, a global north-centric view. The G20 slightly better around the pandemic instrument with One Health and AMR within that. But again, I don't think it's going to gain traction. Cuba is the current chair of the G77. There's been very little from the G77 since 2017, actually, is the last I could find, with a short piece around three priorities. I'm not sure what's happening to the thing. It was mentioned about the IACG What was meant to happen in 2016, well, the tripartite, which is now the quadripartite, yep, we got them involved. The ICG recommended a global leadership group, so you have that now. But the important thing is discounting the issue around a global stewardship framework, which never got off the ground. But the one that we actually need is the independent panel on research. Now, the independent panel on climate change is the body that does the research and provides the evidence for countries to deliberate and make decisions on. We need an IPAMR, and the time is now. If we don't get that, we can't leverage further evidence to show what the priorities of the Global South are. So if I was to try and push the needle to prioritization, is to infection prevention and sustainable access. It is a million miles away from a new gram-negative antibiotic. So what do we need? So Jim Collins was the first to coin this phrase in the setting of industry and companies. A BHAG is a big, hairy, audacious goal. Okay, and I don't think it's far-fetched to expect that the Global South population, citizens of countries in the Global South, should have access to clean water and safe sanitation. There are mechanisms through the World Bank potentially to fund this sort of big, hairy, audacious goal. And I think that's what's needed, that or a infection prevention BHAG, but a wash bag sounds better. We have talked about targets. There will be targets. There's going to be targets around how much countries should use antibiotics in their access group. 60% currently is far too low. We're going to be looking at 80%, I think, probably 90% in communities should be access antibiotics. And Mike Sharland's working with a number of people to model that. The Muscat Manifesto, unfortunately, seems here to stay, although its basis in science is very, very weak. But this was the targets for animal health, and there need to be environmental targets as the antimicrobial resistance benchmark, which does try to hold companies accounting to pollution with antimicrobials, but clearly it's far more than just about that, and we need better environmental targets. Is there an overarching target? Could you make an overarching target like the climate change 2%? Well, it's possible. It's a bit more difficult, but it is necessary in a way because it does unify people, and a global target takes a little bit of pressure away from countries in so much as if there's a global target, you can work towards it. You don't have to have a 2% target yourself specifically. So it does act as a barometer, it acts as a unifying agent. So what would it be? Well, maybe the unicorn target is X% of the world's population having sustainable access to effective antibiotics. But that, of course, brings in a lot of issues around infection prevention and how you get to that point. And it means that countries could have their own priorities and their own listings. So, conclusion, thank you. The needs and the agendas of the two sides of the equator have diverged to such an extent that the global mitigation of AMR is under threat. Now, as Martha quite rightly said to me beforehand, well, what is that? It's always been the same. You know, we always have, this is the issue. There has always been this divide. But again, I think that COVID has given us an opportunity to really use this in policy to try and dictate and try and push policy agendas. Forwarding the agenda of the global north is damaging, not just to the global south, but to the global north itself as well. And it's destabilizing. We need to focus on infection prevention. That's where our countries need to focus on. We don't need a national action plan being funded with R&D and everything involved in it. We need our funding going to the evidence suggests, the present evidence suggests, that we need to focus on WASH and vaccine prevention and then animal health for food security. And I don't think, unfortunately, that including AMR into the pandemic instrument is going to be enough. I hope I'm wrong, but I think we need a standalone instrument, which we need to work towards. With that, thank you.
So thank you, Mark, for this really great presentation that was so rich, and I think started a lot of thinking for many of us, thinking about bang for the buck, and also like for how long time we have known what needs to be done, but how to get there is really, really the issue. And I think that can definitely be saved for the panel discussion. But I want to see if there's any immediate reactions or reflections in the audience to Mark's presentation, because we have time to address it now, or you can keep them for later on. We have one from, yeah.
Hi, Mark. Thank you very much for this presentation. I'm very aligned with everything you said. My only concern is we keep on waiting from one high-level meeting to another. And to even agree to a target, I probably will be a very old woman. So I'm just wondering whether, I know your talk is about high level, maybe some of the messaging about what country can do at the low level, at the regional, at the national level, because the voice could be stronger to the UNGA discussion, with many of us in this room may not be involved in this discussion, may not be even be able to change one word in some of the resolution that will come. So maybe some reflection considering your experience will be great.
No, thanks very much. And I agree. I think we'll probably both be, I'll be even older than you, so it's going to take time. But I think there's two things to say. The first is that I think it's incumbent on each country now to look at the National Action Plan and ask if it's fit for purpose. And it needs, as I said, prioritization. So we need as countries to say, what is the priority for South Africa or wherever, and where should it go? So what is the target set that we need to set around that priority? Now, that's another reason why having an overarching goal, like the 2%, 2 degrees of climate change, is useful, as I said, because it takes away that pressure, and it's not so much when you haven't reached your target, because you can reach targets which will impact on the global good. The second point to make is that there's a second Lancet Commission on AMR underway at the moment. And this second one is modeling trying to model at a country level what the bang for buck would be if you invested $1 in infection prevention, if you in WASH or vaccination, increasing coverage or stewardship or whatever. What is your return? And that will give stronger evidence for each on a country level to show the Minister for Finance, this is what you can do with $1 or whatever. So I think those are the two issues, but I'm interested to know what you think of that.
Is there any questions online at this point that we can address? Not at this point. Then I thank you. Now, Mark, you will come back very soon, and we'll then introduce Murphy Mapundu, because now we're going to zoom in a little bit more on the NAP financing as such. So Murphy will help us to set the scene here. Welcome, Murphy.
Thank you so much. And thanks, Mark, for really coming. It was great that you were able to make it. He came in yesterday. He will be leaving in about an hour or so. So grateful that that time was spent with us. So most of us have actually spent a bit of time on really developing the national action plans. We go back to really 2015 when the Global Action Plan was passed, and we recall about that time there were no tools that were there for really developing and guiding countries. A number of tools that we ended up using in most countries were tools that we developed, and then we worked with countries to do that. And I think one of the earlier countries that we even did costing with Kim Fer was in Zimbabwe. That was that was costed, and our costing then was really based on really our own methodologies that we had used in other health sectors of it. So, the issue about the NAPS has been, have we done enough? Have we moved further? Has the needle moved actually forward? Gad P asked me to do a piece for them that was published in Revive. I mean, you can look at it. So, yeah, so I was thinking, what should I call this paper? I think that was about, in 2022. And I'd made some reflections. A number of us have been discussing, have we made progress? And I think most people thought that between 2015 and between 2017, when we got the new plans, and up to about 2019, we saw that actually the momentum was going down around the, real implementation. A number of countries, as a background, really in this region, a number of countries had their national plans actually funded. And so when we were asking ourselves questions and saying, in 2020, in 2019, 2020, 2021, that, why are countries not implementing? I wondered why we were asking the second question when the first question had been answered that they did not have any money. So how did we expect now the countries that had no money, we helped them develop the plans through, these funding sources, then we are asking them what progress has been made. So it's something, and unfortunately, that's one of the elephants in the room. So I wrote a piece, that I called really moving from paper to action is the greatest challenge, largely due to limited financial resources. In 2022, the same year, WHO did like a Mentimeter at a webinar, what are the major challenges that are there? We were in agreement that, are they, really folks who actually contributed attending that webinar, they put funding as number one. The second one was coordination, that, there's poor coordination among the sectors. And so, those were issues that needed to be actually addressed. Governance was really around the third. Issues that are quite common, we've talked about them, data and all those, I'm not going to go through that. But substantively, this is what we have seen over the last, 2, 3, 4 years. Reduction in financing in really health intervention in the ministries of health, but also, it's a similar thing that one would see in the animal and in the environmental sector, low funding for COVID. Kenya cuts actually funding that threatens HIV and AIDS treatment. And actually, if you look at their funding in 2021, they could only get up to close to 50% of actually funding. Nigeria cut its funding spending, by 40%. We talk about the Abuja Declaration. We shall be able to put 15% of our GDP in health. The only countries I believe, that even got closer to that, I believe was South Africa. Most countries from the Abuja Declaration have never been beyond 7%, 8%. It's far much less than that. And then we pose the question, so how do we fund national action plans? Financing, I know people get tired sometimes to say, financing is an issue. Yes, it is. We can't minimize it. It's one of the major issues that has limited really the implementation of national action plans. There has not been a very good case that has been made, by our governments that, through our ministers of actually finance to say, you know, this is a priority. The World Bank for the last 5 years or so has that funding. And they've called side meetings at the, you know, at the winter and the fall meetings. And, you know, there hasn't been attendance of the ministers of actual finance, the ones that hold the money. Really inconsistencies that we have in data, whether it's, you know, on AMR and research and development. We've had issues around actually costing what really a drug-resistant infection costs, you know, in a Kenyan hospital, in a Nigerian hospital. You know, there are some spots of data there, but it, you know, we don't have much data that we can use to convince and make a case within our own ministries to our politicians. We've got actually our these professional bodies, and I was having a discussion yesterday with the director that, you know, I often ask, you know, how many professional bodies ever make an appointment to talk to their members of parliament? How many of us in here have walked in and said, you know, we got an issue. You are my MP, and I want to show you that, you know, in my health facilities, I'm a doctor, I'm a pharmacist, I'm a vet, I'm an environmental guy. There is no clean running water in my hospital. And what that means, it means ABCD. What is typical for us as professional bodies, you know, pharmacists, doctors, IDs, whatever, we complain when they make decisions, they don't fund the issues we think we are passionate about. We have to engage with the policymakers. We have to make the case before they pass laws or before they release the budget for 2024. We have time now to talk to them and make an argument in terms of why they need to fund actually, you know, national action plans. There are no incentives in the marketplace, you know, to actually do that. Whilst, you know, there has to be a great burden, and I think I was discussing with Mark last evening that, you know, when you work in a sector like this over a number of years, you know, sometimes you start reflecting, where have we gone wrong? You know, has my message on stewardship been, you know, have I done it right? And I've asked those questions. And I've argued now that, you know, we have made certain fundamental mistakes in terms of national action plans and the way we move forward. We take 2 people from a health facility. One province, we take 2 people, another province, 2 people, or 2 people from one country, 2 people from another country. And we said we teach them stewardship for 3 days or for 1 week, and we send them back. We expect that they will go establish stewardship committees that will be successful. Absolutely not. Have I done that? Yes, I've been part of it. I've worked with WHO. We've done that. We've worked, you know, Mark was here in 2015 in Zambia. We had meetings here. I've been to Sierra Leone. We've trained. We've trained in Tanzania. We've done the PPS, done action plans. Ask them a year later, 2 years later, what has happened? Only 2 hospitals have done anything out of the 20 we trained. And I think my proposition is that, you know, if we're going to overcome some of these barriers, issues like stewardship, it's a practice, it's something, it's a behavior, and so we have to be ingrained in it. We have to invest and have staff that can stay in a health institution for 1 year at the very least, because you've got to be on the units every day, do rounds twice a week, do your progressive audits, get the data, and use that data. You know, stewardship training that takes 2 days, 3 days does not work. At least from my experience, I could be wrong, but you know, I'm sure that a number of people in this place will agree with me. Yes, we talk about actually, you know, investing in R&D and, you know, all those things, but I think we need to take an AMR lens to invest in really interventions. And I like the fact that, really prevention was actually, that argument has been made. And I really believe that if we can address the major population that's outside of a very small population of a health sector or a food sector, we look at the communities where, because if we prevent that side, the need for antibiotics and other antimicrobials is actually reduced. Of course, we need research and data in our own what we need actually to cost the value of interventions, and also really ensuring that we take that data and use it. Sources of funding, where will it come from? We talk about domestic financing and funding. I think it's a good theory. How is it going to be done? Where would the local funding actually come from? We are used to having really donor-driven actually funds. We need to create probably private partnerships. Grants have been a major thing that we do. But where will it come from? We need to build a good narrative. I think there are some enabling factors we need to take into consideration if we're going to move the needle further and get financing. We need a good narrative. We need evidence and case studies. We need a sector-wide actually partnership, indicators of tracking. We also need really decision-making tools that can guide the decisions that we make. We need a strong economic case for investments. We need to be able to say, how much does it cost for a patient in the ICU who's on a drug-resistant infection? How much does it cost? Add in doctor costs, electricity costs, pharmacy costs, nursing costs, come up with a figure. We don't have those figures. We need to be able to show that, if they stayed in a medical ward for 3 days or for 2 days, there's this sort of actually a difference, and that goes with the molecules that we had. I will not talk much about the incentives in terms of the pull and the push incentives, in terms of R&D. But if there's a question that will come up, I will address that at that point. Thank you so much.
Thank you, Murphin, for this. And I think several questions that we can start processing on our heads before the discussions around your speech, Murphin, is, both the thing of, how do we engage with decision makers on a daily basis? The encounter between the people in the front line and the people in power, that is very interesting. So if you have interesting examples of that in the audience, that would be really interesting to listen to. And also, as you mentioned, how to build a convincing case. So thank you for that. And now I have the pleasure to invite the next speaker, and it's the last presentation before we go to the discussion. And a warm welcome online to Becca Ketteringham from the Fleming Fund, the Policy and Program Manager, that will join us now and give her perspective on the topic of financing and missed opportunities in AMR and NAP financing in Africa. Do we have Becca with us?
Hi, yes. I don't know if you can hear me. Can you see me?
20 seconds on the clock. Please wind up, presenters. Time up. Please move to the next poster. Please move to the next poster. Twenty seconds on the clock. Please wind up.
Time up, please move to the next poster. Presenters, you can stop presenting so that other people can also come and hear from you. Time up. 30 seconds on the clock. It's time up. There's some presenters who don't have any guests at their stands. Please look around you and move. Don't take too long at one poster. Please, let's shuffle. Mhm.
Time up. Please move to the next poster. Please move to the next poster.
Please move to the next one. Move to the next poster.
Have 10 more minutes only, so kindly move to the next poster. Two more posters to go and then lunch. So kindly move if you haven't.
Time is up. Sorry, I did not give you the 2-minute alert. Time is up. We need to go for lunch so that we come back in good time to finish early enough. You can always interact with the poster presenters over lunch, over 4 p.m. tea, over dinner. Can have, yeah. So time is up, ladies and gentlemen.
I'm very honored for excellent speakers in this session who will be presenting each of their projects and highlight some of the findings that they have until date. So we will be having presentations from Benin, from Tanzania, from Tunisia, and from Zambia. So it's quite an eclectic group. And to not delay this any further, I would like to invite the first speaker. So Dr. Victorien Dugnon is a microbiologist, and he is working currently at the University of Amobi Calavi in Cotonou in Benin. And he's also the project coordinator of this ICAR supported project. Welcome.
I'm still waiting for my presentation to show up here. Yeah. Wait, 1 second. Make it. Okay. So when you're ready. Thank you. Okay, dear participant, thank you very much. It's my pleasure to talk about our project in Benin regarding the important antimicrobial resistance through day-old chicks and eggs. We built an integrative study to support the implementation of a microbiological certification system in that country. So I will go through the AMR challenges in poultry in Benin before coming to the M and the main objectives of this project. We will present our approach, and since we get already some initial result, we will talk about it before going for some learning lessons regarding the implementation of National Action Plan in Benin. So in Benin, we, as many countries in Africa, we consume a lot of chicken meat and egg in all the family. You have at least per day chicken or eggs in the food. But locally, we are facing insufficient local production, and this leads the country to rely on importation of table eggs and day-old chicks from various countries. And we have in Benin this particular system. We have the legal system where the chicks and eggs are coming through a well-known system, but we have also the illegal system. And this one, we use the borders around the country, And this illegal system is a way of a lot of troubles. And we noticed through many research before that AMR bacteria are prevalent in poultry farms and in imported day-old chick. And this one, we had the co-development phase on ICAS project, and we noticed that the day-old chick coming to Benin were carrying some AMR genes. And unfortunately, we have no monitoring system about the prevalence and level of resistance bacteria in imported day-old chickens or egg in Benin. And when we were drafting our national plan, you know, in Benin, the medical system, they have the main place in that national action plan. And the poultry sector was not so highlighted in that national action plan. And at least we recommend that we need to improve the management and rational use of antimicrobial in veterinary medicine, animal, and also plant production. And also, we recommend from our national action plan that a national surveillance system for antimicrobial resistance pathogen in animals should be established through some well-equipped laboratory. It's one of our strategy. But since that time till now, no action has been taken in that regard. And before we started our activities, there were limited laboratory diagnosis for animal infection diseases. And that's where ICAS came to Benin through this project to provide data and a framework to design and support the implementation of a microbiological certification system for local and imported eggs and day-old chicks in Benin. Firstly, we had an in-depth mapping of the poultry value chain in Benin, including all the formal and informal sectors and routes involved in day-old chick and eggs import in Benin. Secondly, we will determine the type and level of antimicrobial resistance in priority indicator bacteria in day-old chicks and eggs imported both ways. Thirdly, we will explore with international, regional, national, and local exporter and importer of poultry in order to understand the condition and set up criteria under which the microbiological system will be able to function in the country. And finally, we formulate some criteria and day-old chicks and eggs import in Benin. And we are working closely with the Ministry of Livestock, Fishery, and the University of Abomey Calavi. And I can say the first day I met the ministry himself, he immediately said, "This is what I need," and I support it fully. And that's why I'm here with his assistant that he sent personally to show up that it's a real matter in Benin. The second work package will be about the determination of the type and the level of AMR in indicator bacteria. We choose E. coli, we choose Enterococcus faecalis, and Salmonella species in those eggs and also the one-day chicks. The third work package will help us to explore through some qualitative survey so that we can assess and define the needed legal framework in Benin to support the establishment of this microbiological system. We will evaluate the costs and benefits of implementing this microbiological system. So it's a link between microbiology, economic, also poultry value chain system, and we will also disseminate the result to the local and international stakeholders, because all those stakeholders are together through the surveys and they are belonging to the study, so that they can have the lesson learned from it. And the last work package will be about the criteria, legislation, and step for a future microbiological certification system for those targets. So we get some initial results. From the co-development phase that we have in 2022 with ICAS, we noticed the presence of multi-drug resistant bacteria, E. coli, Salmonella, Enterobacter cloacae, Bacillus, Pseudomonas species, and also Klebsiella in imported chicks. We noticed the prevalence in the informally imported day-old chicks compared to the formally imported one. It's normal because the informal system lack all the surveillance we have in the country, so rubbish can come and we don't follow anything. We also see that a lot of strains were resistant to ciprofloxacin and gentamicin when considering the legal system and the illegal one. So now, from the current pre-development project we want to map the poultry value chain in Benin. So we had a workshop with all the stakeholders at the University of Abomey-Calavi. So the Ministry of Livestock helped us to reach them. All those people, breeders, food manufacturer, veterinarian, para-veterinarian, the state agent, and also the importer, they were all together, and together we think about the survey that will be built in order to understand the system. We have also this work package, which is going on now, and we are collecting the day-old chicks at the entrance of the country. The legal system, they come through the international airport. So we collect the day-old chicks there, and after that, we release them. And from the illegal system, we have some agents at the borders with Togo, with Nigeria, in order to collect also and do the same exercise. The idea is when we have all the information, we can set up this microbiological certification system. And when one shipment of day-old chick arrive, we do the analysis quickly to see if this shipment is free of those priority pathogens. And after that, we can release or return back the shipment. So that's what we are doing. And what we learn from the intervention and for the NIP's implementation is that before that, AMR in the animal sectors was not so present in Benin. But with ICAS, we support the vision of the Ministry of Livestock, and quickly he said, this is what I need. And now AMR in the animal sectors deserve more attention and action in Benin. And this aspect of NIPs in our document is now benefiting from intervention thanks to ICAS. If not, it will be the same thing we will say every year. Okay, next year we will see how it will go. Next year we will see how it goes. Now we have data, we have action to fit our national action plan. And this project will help to identify what parameters a microbiological certification system will need in Benin in order to be functional. That's the word of our ministry. It needs to be sustainable. It needs to be functional and accepted by all the actors in Benin. So we will know the criteria, the legislation, and the steps that we will follow. That's the message I have for you. Thank you very much. With these pictures in Benin now, we have this agodie. We call them agodie in sign of respect to women that were fighting for our independence in Benin. Thank you very much.
I would just double check. Are there any clarification questions for Dr. Dunyo? Yes, one over there. Yeah.
Okay, thank you, Prof, for your presentation. And actually, it's good example of collaboration between research and the government, basically the enforcement or the policy makers. I just want to look at the tool you are developing, that is the microbiological certification system. I would want to look at it from two sides, the technological and also from the regulatory point of view. From the technological, how quick or how fast will it be to do this analysis when these imports have come into the country? Will you just be sampling a group of chicks or eggs? And will you be using, what kind of methods will you be using? Are they equipment, or you'll subject it to some laboratory analysis, and for how long? And when it comes to the regulation, I don't know whether it has been developed. What parameters are you targeting to have within the regulation so that if somebody brings these chicks into the country and they are not allowed, how will you be able to enforce that? Those two, thank you.
Okay. Okay, thank you very much, Prof. How fast to do the analysis? We know that when a shipment arrives, the importer, they need to have the animals quickly. If not, if they die, it's a big problem. So our willing is to be able to release the result 2 or 3 hours maximum after getting the samples. So we are taking, it's not yet the moment to have the definitive result. We are taking to automatic system in order to avoid any waste of time, because we want to help the importer, not to be a bottleneck for them. So that's what I can say. And about the enforcement, we are relying on the support from the ministry himself. You know, in Benin, when we take decision and the authorities sign it, it's a kind of law. You need to follow it, and everybody try to avoid to be in front of the law. So since we have this involvement of the ministry himself and all his staff, we think that when we finish and present the result, he will take those decisions. And for the short notice, before we start the project, he was even pushing us to take the decision. I was the one saying, no, please wait and let us do it properly before taking the decision, because he is a farmer, he is from the field, and he knows that it's a big problem for the country. And actually in Benin, he is the one leading for national production a lot. They want to produce in Benin. Thank you.
Well, for the sake of time. Okay, thank you. For the sake of time, that was wonderful. Victoria, do you want to sit maybe? And yeah, we will. Oh yeah, please. So we will move on then to the next speaker. So Augustine Matondo is a researcher at Sokoine University of Agriculture in Tanzania. And he is also one of the team members in one of the ICAR supported projects looking at poultry. So I think somebody will help you. Do you know how to do the presentation?
Yeah. No. Yeah. Well, thank you, Anik, for the introduction. So I'll be presenting one of the two projects that are funded and supported by ICAS in Tanzania. So the other one was presented yesterday through the poster. That was mitigation of antimicrobial through treatment of manure. So today I'll be presenting the second one, that is optimization of vaccination and biosecurity as a means to enhance the fight against antimicrobial resistance in Tanzania. So the presentation will have four key areas, that is challenges, then the objective and the implementation approach. And then I will share the initial results since we are still in the early stages of project implementation. And then finally, I will present what are the key learning items so far that we have achieved. So poultry production is important for both for the economy and the food production. But unfortunately, this sector has been faced many challenges, and among the main challenges is devastating losses caused by poultry diseases. And these ones are mostly contributed also through the inadequate IPC, so infection prevention control. And these have led farmers to rely more on the use of antimicrobials, and this in turn have increased a lot risks on antimicrobial resistance. As we know, this resistance can develop not only in the pots or the chicken, but also can reach to humans through food, because poultry products will end up at the plate in our table. So as part of the solution to try to tackle these challenges through promotion of IPC, so the project objective is to try to promote the adoption of vaccination and biosecurity in poultry production systems. And this project will be implemented mainly in 3 phases. And these key phases, phase 1 is situation analysis, where we aim to identify the key area that can be incentive or can promote the adoption of vaccination and the biosecurity, and also the barrier that can limit the adoption, so that when we move to the second phase, we can take that into consideration in order to promote this approach. So in the second phase, that's the implementation phase that is expected to take place at the farm level, and where we are going to promote specific adaptation to what they are currently doing. So we are not going to introduce something new, but we try to promote what they are doing, but also to see what are the gaps that can be filled in order to achieve the intended objective. And during the implementation, this will be done together with the farmers themselves. So we expect also to build the capacity so that at the end of the project, they can continue to do the things that they have learned. And during that time, we also monitor the achievement if the implementation is working through monitoring of diseases, the antimicrobial use, as well as the economic benefits that the farmers will get. So finally, we expect that the good things will be scaled up, and this will be done through training and also as the team. Among the team members, we have economists that will help to develop some kind of business model that the farmers can adopt. So the project was implemented in the eastern part of Tanzania in 3 study sites, so in Dar es Salaam, Morogoro, and Zanzibar. And so far we have done the situation analysis, and we have reached 202 farms. And from this, we present what type of data so far we have, as I said earlier. So we have not done yet with the data analysis. So what I'm going to present today is just preliminary information that we have. So far we can see that the information we get is encouraging. And so we could see, for example, the status of vaccination against the very common diseases that are known, especially Newcastle disease, infectious basal disease, and cowpox. So the vaccination rate is very good. And this is somewhat not surprising because a lot of effort have been implemented so far to promote this vaccination. And it's also encouraging that for some of the diseases, especially those caused by bacteria, so the vaccination rate is very low, but based on the results from the viral diseases, we expect if similar efforts are invested, it's possible to achieve the goal as you have seen in the viral condition. So we also inquired about, so what are the common signs that reflect the diseases that occur in the poultry farms? So the most mentioned clinical signs were those related to diarrhea and respiratory conditions. And the one that commonly associated, for example, with central nervous system like stargazing, cycling, and others were very low. So that indicates also possibly, as we see in the previous slide, the vaccination rate, for example, for Newcastle disease, which is one of the disease that cause this central nervous system signs, was very high. So it is possible much of these clinical signs that we see are not related to Newcastle disease. So what we can take from this result, it's possible that possibly these signs that are very highly reported are most related to those diseases that are not vaccinated against. So if we implement efforts in the intervention in other signs, it's likely that we can somehow reduce these as well, and the diseases that are causing this sign. So other potential area of intervention that we have identified so far, so from this preliminary analysis, we have seen that there are some area of interventions that are related to knowledge, attitude, and practices. For example, 18 out of 100 farms that we visit, they do not agree that vaccination can reduce the need for the antimicrobial use. So similarly, so 28%, they don't see any need to vaccinate diseases that can be cured. So this means that we need to invest effort to show evidence that can show these farmers that there is possibility not to use antimicrobials if they can prevent the disease through other means. So similarly, there are some practices related challenges. For example, some more than almost 50%, so 47%, they use chlorinated water to prepare the vaccines. So taking into account that these vaccines that they use, most of them are live attenuated vaccines. So there is a potential vaccination failure. And that's why it's also not surprising to see that 70% of these farms, they encountered diseases after vaccination. Although this can be maybe due to other factors, but this can also be one of the factors causing this as well. So we also saw that almost 75% of the farms that we visited, they only know the vaccines that are highly promoted. So this means that if they are become aware of other vaccines, the chance of raising or increasing the adoption of vaccination of other than those that are currently being used is high. So finally, to conclude, I'll say that what we have learned so far is we have from the initial data that we have seen. So we have seen gaps that are existing in terms of knowledge, attitude, and practices on vaccination. And there are also policy issues such as vaccine availability and affordability and quality control. So this one were not presented here, but from the result we can see from the response that we received from the farm. So if indeed we want to promote IPC in livestock sector, so we need to take a lot of consideration and also to try to change things on the ground if we need to see the changes, actual changes that in terms of disease control. So I would like to thank the team members. So although I'm standing here in front of you, there are other almost 15 members of the team that participated in this study. So they are not here. So from the pic, some are in the picture that you see, and some also from the technical support from ICA's team. And some you see are those that are field assistants that assisted us in collecting data. So in this project, we also collaborated with the Ministry of Livestock and Fisheries. They are part of the team. And the Zanzibar Livestock Research Institute, they are also part of the team. And as we can see, the team comprises of researchers and the key members of the policy advisors, the ministry. And this was in purpose because that will also assist us in taking the message where they need to implement, where in case of issues that are related to policies and other interventions from a higher level. So thank you very much for your time.
Any questions for clarification from I guess that meant it was very clear. Well done. Okay, thank you so much. Okay. Then our third presenter is Dr. Wajdan Mansour. She is a microbiologist and an associate professor from the University of Sousse in Tunisia, and she's the project coordinator of the Tunisian part of the Envire project of JPI-AMR.
Thank you. Thank you very much. Thank you for ReAct Africa and the South Center for this invitation and for ICARS also. So my intervention will concern a part of the GPA-AMR project, which is co-funded by ICARS. Our project is related to intervention to control the dynamics of antimicrobial resistance from chicken through the environment. And I'm Dr. Roger Mansour Asset Payanik, and I'm in the Faculty of Medicine in the University of Sousse of Tunisia. I don't know exactly how do you know about Tunisia. So Tunisia is a Northern African country, and it's known for a beautiful beach, but also for a very delicious and tasty pastries. And also to be, unfortunately, the second biggest consumer of antibiotics in the world, just after Turkey, but without, without any significant difference. So the use of antibiotics has increased large with 38% between 2005 and 2013. And this leads to the increase of the profile of resistance, especially in gram-negative bacilli, but also in cocci and gram-positive cocci. About the Enviro project, as I said, we in Tunisia, we are a partner of a consortium of 5 countries, 4 in the European country and Tunisia, and the Tunisian side is financed by ICARS. The study aim of this project is to deal with proposing a therapeutic alternative to the use of antibiotics in chicken farms. And also we have an action in the environment point with the pollution of poultry farms effluents using such a matrix to attach the different residue of molecule of antibiotics molecule to reduce the selection pressure made in the environment and leading the bacteria to become resistant. So at this stage, after we begin in May 22, so at this stage, we are advanced, we will say, in the first aim, and this will be explained in the next slides. So for this therapeutic alternative to antibiotics, we are thinking to use plants, so phytotherapy in chicken farms. And to manage this target, we made 2 types of study, a descriptive study to have a comprehensive idea about which bacteria we are confronted in the poultry environment and in poultry sanitary in general, and an experimental study to use this plant to treat or to prevent the infection in these broilers. For the descriptive study, we've made, so this is the methodological, it's bacteriology, classic bacteriology method with local swab and then culture media on media additional by antibiotics, etc., phenotyping, genotyping. And we detect at this stage 11 of the ESBL, standard spectrum beta-lactamase. It's the kind of enzyme that promotes resistance in bacteria. We made it also for about 546 chickens, and we retrieve also the ESBL E. coli. And so we have a comprehensive now idea. We know that you are facing this E. coli ESBL in broilers production. And we moved to the experimental study targeting this bacteria. So in the first term, we use a first experimental study, classical one, just to see what is the effect of the plant that we are proposing to use as an alternative. And then we have, as you see here, 3 batches with a control group. With the group, when we use food, normal food, but we use water additioned by antibiotics. It's not legal, but we use it for just for experimental issue to compare the results with the third group, which was fed with classical food, but additioned by the plant that we proposed, which is thyme and rosemary with a ratio of 20 per 1,000. And weekly, we do the body weight and cloacal swabs reaching for antimicrobial resistant bacteria and specifically for ESBL E. coli. So without entering into the statistic details, but if we are looking to the third columns in day 38, we see that in terms of body weight gain, we were surprised that we have not the biggest or the best result for the thyme and rosemary powder additioned to food, and which lead us to propose other amounts and to reduce a little bit the quantity of thyme and rosemary. In terms of mortality, we have a very good result regarding the use of thyme and rosemary. So no mortality was detected in the batch. And regarding the production of ESBL, we begin to detect multi-drug resistant bacteria in day 21 of the experiment. And then naturally, all the other batches were contaminated after that. The second experimentation was done with an artificial colonization by E. coli ESBL. So we put the E. coli ESBL in these chickens. This was the case for the group 2, 3, 4, and 5, and not for the negative control, of course. So for the group 2, we have the positive control, which means colonized but not treated. Group 3 colonized and treated with classical antibiotic scheme. Group 4 fed, but in this time with 10 grams per kilogram of thyme and rosemary, and the group 5 was fed normally, but we have the water with hydrate of thyme and rosemary. And we have to notice that we faced the challenge of very high temperature. This experimentation was done in June, July, beginning 6th of June, I think. We faced the challenge of very, very high temperature in this period, especially in July in Tunisia. And we have reached even the 42 and then 45 degrees also. So this was also challenging for our experiment. For the results, very promising results regarding the thyme and rosemary powder, no mortality, just like the first experiment. We have no mortality in the batch when we feed with classical food additioned by thyme and rosemary. And also regarding the body weight. Okay, so regarding the body weight, we have concluded that the use of 10 grams per kilogram of thyme and rosemary was very, very, very good ratio. So as you see in the result, we have a very good body weight comparing to this one obtained with the antibiotic batch. So as a conclusions, yeah, we have seen that preventive antibiotic use, we confirm that because that is I think known that the use of antibiotics led to the selection of E. coli ESBL in broilers. The use of thyme and rosemary, we concluded also about the amount or ratio of the usage of this plant. And we are also very glad about the fact that the use of thyme and rosemary ensured 0% of mortality in all our experiments. Next step, we will have a third experiment And in this one, which will be made programmed in November 23, we will treat diseases. This will not be a preventive treatment, but we will treat diseases, colibacillosis, caused by E. coli. And after that, in 24, we plan to do an industrial model to have a more representative results. And also the second target is in progress related to this pollution of wastewater coming from effluents. Finally, I would thank ICARS, all my team, my colleagues, my students, and thank you all for listening.
So Wijden had promised me her presentation would be 9 minutes, and you managed in 9 minutes. Thank you. Any clarifications? I think this is a bit of an unusual project compared to the other ones that ICARS usually supports. So are there any questions? Any microbiologists in the room? No? Anything online? I guess not. No? Okay. Thank you, Wijden. Thank you. Okay, then I forgot my paper. So if I forget the long list of things I have to say, the last presenter, it's my honor, Dr. Duncan Chanda. He's an infectious disease specialist and he works at the University Hospital here in Lusaka. Oh, you're sitting right there. Good. I was looking for you in the back. It'll be a bit different. It's not on poultry, so it's actually on humans. So it's a nice change.
Good afternoon, everyone. Yeah, thank you. First, I'd like to welcome you to Lusaka, since I'm the host PI under ICAS project. I would like to thank ReAct and the South Center for this opportunity, first for hosting this conference here in Lusaka, and for the opportunity for all of us to share our experiences. I should say I'm also impressed with the amount of projects which are coming in from non-human health sector, because in most conferences we are heavily skewed towards human health. Indeed, that's the way we should be going as One Health. I'll just briefly describe our demonstration project, which is sponsored by ICAS. We have been running slightly over a year now, and we are right in the middle of the implementation. So that's a brief outline of the presentation. So we know in clinical practice in most countries, of course, urinary tract infections and bloodstream infections are associated with extensive use of antibiotics. And this, of course, contributes to the drive towards antimicrobial resistance. In Zambia, in particular, BSIs and UTIs have been recognized as clinical syndromes associated with antibiotic use. The antibiotic misuse is reflected in high levels of antibiotic resistance in survey data collected at the tertiary health center here in Lusaka. That's the University Teaching Hospital. So basically, the aim of the project was to optimize use of antibiotics in UTIs and BSIs by 20% reduction of use over a 3-year period by introducing antimicrobial stewardship across a continuum of care. I don't know in other countries, largely our experience until very recent, most antimicrobial stewardship activities were really limited to high-level hospitals, such as teaching hospitals and tertiary hospitals. But when you go lower to the primary health facilities, Their antibiotics are prescribed like a matter of fact for anyone who walks in there. They're going to walk out with an antibiotic. So our objectives of this demonstration project was to assess the baseline and endline knowledge, attitudes, and practices of antibiotic use of the prescribers and patients at both primary and tertiary level facilities, to facilitate training and develop skills of healthcare workers in antimicrobial stewardship along continuum of care, to co-develop an AMSC program and implement tailored AMS interventions with relevant stakeholders. So we chose the hub and spoke model as a way of demonstrating how we can actually use a higher level institution like our teaching hospitals to support lower level institution into microbial stewardship. So basically, we have got 3 tertiary hospitals here in Lusaka, Zambia, in the north of the country, in Dola, south of the country, the tourist capital, Livingstone. And in each case, these institutions are supporting 2 lower level of facilities, meaning level 1 hospitals. So how did we go about this? So the implementation strategy includes a situation analysis at each institution. Then afterwards, we moved on to education in terms of short courses, in-person short courses, then implementation of the program, and then we have continued to monitor and evaluate, and then in the future, of course, we shall be doing dissemination. And as we go along, we are also looking at the sustainability planning. So we did situation analysis. I think that was in between March last year, up to somewhere about August in all the institutions. Some of the methods we used included focus group discussions, and also in-depth interviews, especially with prescribers, to really try to appreciate their understanding about their prescription environment. For instance, we have standard treatment guidelines, but when we ask prescribers, you'll find 40% of the prescribers are not even aware of standard treatment guidelines. And most of these prescribers relied on their experience from their mentors during training as to make decisions about their prescription. And also we noticed there was very little in a way of prescribers actually getting on-the-job training in terms of antimicrobial stewardship and antibiotic resistance and their prescription behaviors. In the 3 tertiary hospitals, we found, let's say, antimicrobial stewardship committees which are functional to about 70%. And then we had to engage with management to try and get this committee 100% functional in terms of getting formal appointments, getting time for antimicrobial stewardship, and getting hospital support and resources. Luckily, of course, ICAS also is supporting us adequately in terms of resources in this activity. Together, we have developed AMS education materials and which are being used actively. And we are actively working on a costing cost evaluation study. So why this? I think one of the issues with AMS, just like NAPS, is we don't really know the cost. And it's actually a very big, a difficult situation we find ourselves in, because most hospital managements, first, they don't budget for AMS activities, and they don't see the need for AMS activities. And it's only now that we are demonstrating that cutting the use of antibiotics, implementing IPC, and all those are going to bring down the cost and the length of stay of the patients in the hospital. We have ably demonstrated this especially at the University Chief Hospital here in Lusaka. But what are we going to do at the lower level institutions? We recognize the urinary tract infections constitute quite a significant burden of disease at primary healthcare facilities, and almost everyone who gets a dipstick and gets some funny abnormal result, they actually get a medication for UTIs. One of the mental illnesses, I was just shocked to find most women who come with a lower back ache, they assume to have a UTI and they get an antibiotic, and pretty much 90% of the people are getting antibiotics. I should say that during the short period we have done the intervention, that ReAct drastically dropped to try and understand how to use the syndromic management. I'm not a health economist, but our health economists and social scientists actually has done a pretty good job. We submitted the protocol to the ethics and have done the baseline costing, which they're still working on the analysis. And we would want to demonstrate the cost at baseline, and then after our intervention, after 1.5 years, and see if we actually we are going to have a case for hospital budgets. I'm very confident that will be demonstrated. Yeah. I won't dwell on this much, but basically that's the methodology they're using for costing. So what are our expected outcomes? We anticipate increased compliance to treatment guidelines. And the other activity, which I haven't mentioned, we are actively building local antibiograms in all the institutions. A little bit difficult at primary care level, but in terms of the tertiary hospitals, that has become quite an active area. And we just reviewed the antibiogram for University Hospital Lusaka now, and we are doing that for Livingstone and the Pondola, which is quite exciting. Also, because of the PPS we have held, including with our colleagues from Bright Collaboration, I think there should be a poster right in the middle there. Also, they're talking about hub and spoke model, and we have done a lot of PPS. We have seen a slight trend now of antibiotic use going down, especially in the surgical units. I don't know about the experience in others. My initial PPS in the surgical unit, it was quite shocking because like 85% of the patients were on antibiotics, but then it wasn't even clear why they are on antibiotics to start with. Then, of course, after engaging, we learned something like they'll give a prophylactic antibiotic when they're about to cut, and then afterwards, someone forgets to close off and the patient is on antibiotics for 21 days. Yeah, just crazy things out there. Yeah, but we have been engaging actively, and we can see some rationality coming in. Yes, so we expect appropriate antimicrobial use at the end, and evidence-based management of UTIs by having local antibiograms, of course. We hope to contribute to the revision of both standard treatment guidelines. In this case, we have actually actively engaged the ministry, but also through Fleming project, my colleague, Dr. Chileshe, and others have actually been doing sentinel surveillance across the country. I think there should be a poster in the corner there. And this is providing us with a lot of needed data for us to put in to base our national treatment guidelines on. And establishment of model AMS sites to provide training for other institutions. We really have to maintain this hub and spoke model. As my worry would be beyond the demonstration project, if the Ministry of Health of Zambia doesn't take on this, then we are in trouble. But we have been actively engaging that, also to the extent that we have come up with a national antimicrobial stewardship guidelines through the Zambia National Public Health Institute. So I think it's something we are glad that it will stand a test of time. Of course, we anticipate reduced costs, which is what most hospital management will be more concerned about. Challenges are continuous in this kind of projects, and of course, basically in our health sector. Lack of antimicrobial stewardship leadership at the facility means that we have to continuously engage. Then some of these problems, strange as they might sound, we have quite a turnover of staff. So you train one group, the next, after 6 months, the people at the top have been transferred to another health facility. Then implementation and compliance to local guidelines. Then analysis of like at some levels, they are not able to analyze PPS, but I think we have found an intervention on how we're going to go around that. Like I mentioned, staff attrition, especially antimicrobial stewardship community staff. Everyone has been talking about limited laboratory capacity. We have beautiful laboratories here in Zambia, but the issue of consumables haunts us daily. That creates another problem for us. We train clinicians actually to use microbiological data to make decisions. Then as they keep on sending samples to the lab, the results stop flowing back and they stop asking. And then when we have the reagents, we've got culture bottles and everything, they expire because we lost trust with the clinician. I don't know, it's something really we have to get around. Then at facility level, again, there's very limited monitoring and evaluation of most of these activities, and lack of quality improvement policies also contribute to this. So when we are not so attentive, people are supposed to be having monthly antimicrobial stewardship meetings. They're supposed to have bi-weekly antimicrobial stewardship rounds. But if there's no one actually paying attention, monitoring that thing is happening, then we lose course. So basically, that's where we are with our project. I think the bigger part right now is we are currently collecting the blood culture data from the 3 big hospitals. We have just finished collecting the UTI data from the primary care facilities as of last week. Thank you very much for listening. Thank you.
Some questions. Yeah. Are there any clarification questions for Duncan? Also, another very clear presentation.
There is.
Oh, there is? Oh, great. Where? Oh,
Yes,
yeah,
please.
great. I didn't see it.
Thanks a lot for the presentation and congratulations on the amazing work taking place. I just want to have a question. You mentioned you did have a situational analysis at the beginning. So did this mean the cap that you did, or you managed to have like a baseline understanding for the consumption and utilization at the levels that you were working with? Sorry, and the second question is, was there different interventions on the primary healthcare level than you did on the hospital levels as well? Thank you.
Good, thank you very much. Yes, so the situation analysis included the cap, both for prescribers and for perceived stakeholders for antimicrobial stewardship in the institutions. And then we did focus in-depth interviews for prescribers, particularly to understand some things we picked from the focus group discussion. For instance, you'd find a large percentage of healthcare workers are not aware of standard treatment guidelines, but they've been practicing for some time. Of course, it was more also associated with the area that come into practice, the more they're likely to have that. And then we then went into in-depth interviews to understand how all those decisions about, I wish I had put a slide on that, about prescribing actually came about. Then from the community point of view, of course, there wasn't awareness of what an antibiotic is. Everyone who goes to the hospital, they're expected to get an antibiotic, especially if they think they have a fever or they have a flu and things like that. So when we are actually doing our training materials, we are based on what we found in the focus group. So at the primary care level, the materials are different, and also even the way we are structured, the antimicrobial stewardship are a little bit different. For instance, we struggled with the concept of antibiogram at that level, and but if we followed the guidelines on syndromic management, everything just fell in place. So like the focus there is syndromic management, but they have to reduce the use of antibiotics just overall, because almost everyone was getting an antibiotic. Then at a higher level, because we have a complement staff, pharmacists, infectious diseases doctors, nurses, IPC people, we pretty much stick to like WHO standards. I do stewardship rounds. Then we've got consultants at the other two hospitals. Then ever since we introduced the program, for instance, the pharmacists are actually keep guard, and when a high-level antibiotic is prescribed by some like a non-ID consultant, then they reach out to us, and then we have got a discussion with our colleague, and then make them understand that the patient provider need that. It's quite a lot of work, but it's also very satisfying to see that we have really dipped in terms of use of high-level antibiotics now. Yeah. The other question, oh yeah, I did answer that. Thank you. Yeah. Are we done?
Yeah, thank you.
Thank you.
Thank you so much. One more hand for Duncan. So we have one more question online, which then it's for you. So maybe you want to come up here and then, yeah.
Good afternoon. Yes, my name is Mutoba, but I'm reading the question online from Ahmad. They asked, beautiful presentation, Dr. Mansour. On what basis did you choose the amounts of thyme and rosemary? On what basis did you choose the amounts of thyme and rosemary?
Okay, so we made in vitro experiments in the laboratory to track the antibacterial activity of some plants. Thyme and rosemary was, I think, the 4th or the 5th plantation. So the amount was arbitrary in the first time. And then we moved to reduce, and we saw that the results come with a reduced amount of thyme and rosemary.
Okay, so thank you very much, everybody. I'm sure we are excited for next year's REN conference, where we'll see even more results, hopefully from these 4 projects, but also some of the other projects that you saw the posters of last night. And one more huge round for our presenters for their great presentations and interesting work.
Good afternoon. By default, I find myself here, and that lady in white is the one who should be here, right at the back. She's part of us. Bertha, come, Bertha. I was looking for you. So we will have an icebreaker, but in form of an AMR skit. I think we all agree now we really do need to engage our youth, and they will perform. I want Bertha to explain. Come. So Bertha is part of our team, our ReAct Africa team, and she works with Julian to coordinate the AMR leadership program. So she'll explain why this team is here. Yeah, thank you. A round of applause as she comes, she's shy.
Good afternoon. At the beginning of this year, we had a My 10 event in Uganda, and we had students come in, make presentations, and these are part of the people that did well in their presentations, and that's why they are here. And we decided to bring them in so that they could show us part of the work that they are doing in Uganda. Please welcome them as they prepare for their skit. Thank you.
Good afternoon, everyone. My name is Tusingwire Daphne. I am a third-year medical student from Kabale University in Uganda. We are here as 5 students out of 10 in a group which we named WAVE. This is a group of young students. We are all in 3rd year medical school, and we have decided to raise awareness about antimicrobial resistance. We have 3 projects so far. The first project is it is an app. We called it the My AMR Alert application. This is an app which we have developed from zero. We made the app, we added in specific features which can give daily reminders about AMR, how to control it, and all that. And we also thought of the people who may not have smartphones in Uganda, and we put a service of a USSD code. You can dial it, and they give you the information for free. However, this app stopped somewhere due to shortage of resources, particularly partnership and funding. Then the second project is about the My Mother, My AMR teacher. One of us presented it as a poster presentation over there. We are looking at sensitizing our mothers to be the sole sensitizers of their children before the children can go into school, they should know that they are not supposed to self-medicate. They should know how to deal with medicine, to only take medicine prescribed by health workers. And the third project is the reason as to why we are here. This is the AMR skit. We realized in our generation, the youth are the future that we are looking at. And entertainment of all forms is enjoyed by almost everyone. And because we get fun through it, people take long to forget what they have learned from it. And it has come to our notice that in this era, almost everyone has a smartphone or a TV at home or a radio, and some read newspapers. So it opens our mind that we can use what people interact with quite often, and we can entertain people at the same time educate them. So through those platforms, when we look at that photo, the very first time we acted this skit was in the Wow Week of last year. You can see in the background, there is a banner of the Wow Week at Kabale University. It was the first time that we acted this skit. it was not just the most entertaining part of the session, but also the most educating. And right now, students, at least they know what AMR is compared to then. And the same way, this kit was also presented at the My Turn Uganda AMR Symposium last year. This event was being sponsored by ReAct Africa, ILRI, SAS, and all the other organizations, and it is the reason as to why we are here. We emerged as the best in this competition. Like you can see, that is live stage drama. When we finished it, we did not stop there. When we went back home, we decided to continue sensitizing the population. As you can look at that, we decided to join to go to these schools, the most populated primary and secondary schools in Kabale district, where our university is. And that was part of the session. Yeah, so primary children and secondary school students. So as we feel that our skit can pass on the awareness about AMR, and yeah, it is coming up next. We request you give us your attention. Thank you very much.
Stage is a skit about Daphne, a girl who died of a deadly group of AMR resistance.
You girl, you remember how you said campus is fun?
Yeah, right.
This is time for me to see what campus really is.
Oh.
Just know I'm even going to buy the other big phones. Campus. And wait to hang up. I've reached where mommy is. Don't hang up. Don't hang up.
Okay.
Mommy, I'm back from shopping. Check out what I bought.
Oh, my daughter, welcome back from the market.
Thank you, mommy.
Have you gotten everything you wanted?
Mm-hmm.
Oh, thank God. Daphne, you are going to the university.
Yes.
Isn't it?
Yes.
And you also know the situation at home, especially with my farm. Every time I receive calls of my cattle dying, and for my tomato plantation, the tomatoes grow and wilt. They grow and wilt. My daughter, I'm very worried. Putting a lot in your studies so that you come back and help us at the village, okay?
Okay, ma'am.
Okay, so I was at the drug shop, got for you some medicine. Every time you feel sick, even a little headache, a little fever, no need to go to the hospital. You can always go pick from your medicine tin, okay?
Okay,
as you have
ma'am.
always done here, your little siblings, I always give them, okay?
Okay.
Yeah, so go to your room and pack. Tomorrow you'll be setting off for school.
Thank you, mommy.
Okay.
Hello, Fosca. Are you still there?
Yeah. So I just heard what mommy told you. I hear stay away from boys, be in your room by 6. I mean, don't be misled. I mean, these boys are not bad people. In the end, you won't die a virgin. This is time for you to explore your youthful stage, isn't it?
What if I get infections or pregnancy?
Nah, that's not an issue in the current generation. You should only fear pregnancy. But anyway, contraceptives are there. As for infections, you can always buy medicines from the pharmacy and swallow.
Are you sure?
Yeah, it works. It has always worked for me.
Anyway, let me finish packing. We'll talk later.
Okay.
And the next day, Daphne reports to campus for lectures.
So students coming today, this lecture, we have covered the course of the brachial artery. We have seen how it is moving the arm, the forearm, reaching the hand, how it is dividing into the ulnar and radial artery, the elbow. We covered it free from now. From here you go the this point I have given you so that you can be better when we meet next time. Are we together? Thank you for coming. We meet.
Hey, girl.
Hi.
How are you doing?
I'm good. How are you?
I'm good. Have you heard of the Teens Night Out?
Teens night out.
Yeah.
Where is it?
It's happening at Club Ambias every Friday night.
Are you sure?
Come on, you should, as we enjoy together.
Okay. I'll be letting you know.
Oh, sure. Let me give you my number. You call me and I pick you up, right?
Yes.
So I am Moses.
Moses.
Yeah, I am Moses.
Okay.
It's lunchtime. Can I take you for lunch?
Yeah, sure.
All right. Thank you. That evening, Mama Daphne comes back from her farm complaining about the animals and the wilting of the crops.
Oh, Matonda wange. What are your poor people going to do? Every time reporting deaths of my livestock, the chicken, they are sickly, my cattle are dying, and my tomato plantation wilting. How am I going to sustain my daughter at school? I'm really very worried. I should consult the chairman.
Hello?
Mr. Chairman.
Hello, Mama Daphne, how are you?
Mr. Chairman, I'm not doing any better. Now that my tomatoes are wilting, I don't have any idea of the cause of all that. And for my cattle, I can't tell the whole story. Mr. Chairman, I'm very worried.
Don't worry, Mama Daphne. I think I can help you with my fungicides and pesticides and use them on your farm.
And what are those?
They are farm medicine. They'll help you. I bought them from the veterinary shop for my farm and used some. They helped me and they will help you too.
Okay, Mr. Chairman, thank you. Let me come for them.
And on that Teens Night Out, Daphne and the friends go to Club Ambias to enjoy. But I think I should take you to my place.
Yeah, tired.
Later that night, Daphne and her friends go away when they are drunk. Daphne sleeps at a friend's place where they had sexual intercourses from. This happens to be the lifestyle of Daphne over and over again. And on subsequent times, she gets infections.
So once again, students, I want to welcome you to today's lecture. Last time we covered the brachio artery discourse. Today we are covering the muscles of the upper limb. We are beginning from the brachium, and we cover more parts.
Hello, Daphne. Yes, I did. But I told you to always buy medicines. These medicines are available. You can buy and always swallow. Actually, you could use some amoxicillin. Yeah, it will work for you.
Students, I want to appreciate your efforts in today's lecture. We have covered the muscles of the upper limb. We have seen the biceps brachii. We have seen the triceps, the other muscles. We have seen their origins and their insertions. From here, go back to the library, visit the e-platform and other sources of information so that you can new content and you improve your mind. Are we together? Okay, thank you for coming. We meet again in the next lecture.
You don't look to be okay. What's the problem?
I am not fine. I have stomach ache, have lower back pain, lower abdominal pain. You know, I'm not okay. But don't worry. I'm going to buy some amoxicillin. I'll be okay.
Oh, sorry. Don't worry. Last time when I was sick, they gave me some amoxicillin and I left some of the drugs in my room. Can I take you there and then you have some amoxicillin? I have some. Don't buy. Don't buy. Okay, okay, okay.
And for all the time.
And for all the times Daphne fell sick, she did self-medication, which involved use of antibiotics without being prescribed. Lucky enough, Daphne still graduates, gets married, and starts working. Oh, sweetheart, how are you doing, sweetheart?
I'm not fine.
What's the problem? Have you taken your usual medicines?
Yes, I took the usual tablets, but there is no significant change. In fact, I am worse.
Oh, sorry.
Did you pick Junior from school?
Oh, yes, I did.
Okay.
Let me take you back home. You have some rest. I'll call the doctor tomorrow, right? Don't fall. I think it's very urgent. Let me take you to the hospital. Let me first call them. Let me first call. First rest. Let me first call. Hello, doctor. Doctor, I'm coming. Sick. My wife. Yes. She's very sick. I'm coming, doctor. But I think we are taking a very long road. Where's the doctor? I called her. I called the doctor. My wife is dying. Where's the doctor? Where's the doctor? Will you be okay?
Welcome, Daphne. How are you feeling today? I have headache, low abdominal pain, and I have fever. I don't know, doctor.
How long have you had these symptoms?
About 24 hours.
Hello? Yes, ma'am. Are you getting me? I am getting you. Okay, okay. Yes, I think it was the network. We are at Mulago National Referral Hospital. Yes. Yeah, Daphne is very sick. We are at the ground level, room 2. Yes. You're coming? Oh, thank God. I've been so worried. Thank you. Thank you. I'm waiting for you, ma'am.
All right. We are going to run some lab tests. Meanwhile, the nurse will take you to room 4 for further examination.
What's wrong with my daughter? I'm asking you, what's wrong with my daughter? She has never been that ill. Did she take amoxicillin?
Yes, mommy, she did.
Are you for real?
Yes, she did.
Or is you tell her to take her medicines, go just to the drug shop? What's wrong?
I gave her usual amoxicillin.
I need to talk to the doctor myself. Where is the doctor? I find my daughter. Sure, it has her medicines in the bag. Daphne. Doctor, what's wrong with my daughter? It has been 2 weeks now. Her condition is just worsening. Take a seat, both of you. How are you doing? Doctor, I'm only worried about my daughter. How about you, Moses? You don't look good either.
I am not okay.
Have you sought medical attention?
Yes, doctor. I went and sought medical attention.
Did you complete your dosage?
I swallowed some medicine, but then after 1 week, I had to go to the hospital, to my fish landing site and work. So I forgot my medicine at home. But when I came back after that 1 week, I made sure I complete my dosage.
Doctor, please, can we talk about Daphne? She's dying. Oh, has Daphne been taking drugs without a doctor's prescription? Oh, doctor, that's what we do at home. Me and my children, we always take those drugs, and Daphne since childhood, I've always been giving her amoxicillin every time she falls sick. And for my children, buy medicine from the drug shop, medicate them myself. Due to fear of hospital expenses, it has been working for them by the way.
Have you heard of antimicrobial resistance?
Doctor, what is that?
Well, antimicrobial resistance is when these small disease-causing organisms refuse treatment using drugs. It has been identified in all other sectors, such as agriculture, that is crop and animal husbandry, fish and poultry. And it has caused the death of many people, livestock, as well as crops of many farmers.
Doctor, so you mean AMR caused the death of my cat? AMR? You know, Daphne was still schooling. My cat was died, and my tomato plantation, it was wilting because of the tomato blight disease. Agriculture in my community, it's not doing well.
By the way, even at my beach landing site, there came a man who was teaching us about how farm medicines move from the farm through the environment into the fish and to the humans. But from the farm to the humans? Really?
My son, no, that's witchcraft. Doctor, can we talk about the cause of AMR? What's AMR?
Well, one of its causes has been the irresponsible use of these drugs, such as antibiotics, antifungals, pesticides, and insecticides. This has made these disease-causing organisms stronger, rendering our drugs powerless. That is why, ever since Daphne was brought to the hospital, she has not been responding to our treatment. And the results of such a condition can be fatal.
My daughter. Come, see. Okay? Dr. Daphne, don't die. Get her drugs. Get her drugs.
Time of death, 7:30 p.m. And just like Daphne, many people have lost their lives due to AMR. Agriculture suffers the same fate. However, antimicrobial resistance can be prevented through the collaborative efforts of the different stakeholders in upholding the different preventive measures that have been put in place. And through such collaboration, we will leave no one behind.
Yeah, that is the skit I was telling you about. Has been acted many times. This is actually the 6th time, but it is not yet recorded. So the information keeps between us who are acting it. So in case of any partnership, would like to take it to the world. My name is Tusingwe Daphne. I was acting as Daphne in the skit, the girl who just died. Thank you.
My name is Bosua Moses, and I've been acting as the boyfriend and the husband of Daphne.
Thank you very much. Timothy Mugara. I've been acting as the lecturer, the nurse, and the chairman.
My name is Nabijako Christine. I acted as Daphne's mother. I think I have caused the death of Daphne.
My name is Musime Fosca, the doctor stroke sister.
Thank you.
I think they deserve another round of applause. Thank you so much. Thank you, Uganda team. Yeah, and as I said, if you're interested in building more capacity amongst our young guys, yeah, see them. In Kenya, we say, if I translate directly, we say, see me behind the tent. It means, for a serious conversation. So, yeah, great.
Thank you. Yeah, so those who know Swahili, we say nione nyuma ya tent, literally see me behind the tent. So I think we keep advocating for this young generation, in whatever way that, it doesn't have to be digital. This really speaks to the common person, if I may put it that way. And as we have heard from Mark, from Murphy, from, even the other speakers, we really need community engagement if we're to go anywhere. So now we move forward, and I've left my paperwork. We move forward to breakout or parallel session, right? I'm correct, right? Yes. So we have AMR and gender. We have framing AMR, people-centered framework, and we have environment and waste management. So gender goes to room 1 across. Framing AMR remains here because, and maybe I need to apologize, also Sarah Pauline is joining us virtually. I don't know if she's still there. Yeah, so the framing AMR and people-centered framework has to stay here. And then room 4 downstairs is environment and waste management in AMR. So ideally, we are supposed to go on for the next 1 hour until 5:30. Then you can enjoy your evening. However, the advisory board members kindly meet downstairs, room 4, at 5:45. So meaning those guys in room 4 by 5:30 sharp, you need to clear off, right? So enjoy. Do I have anything else to say? No?
Yes, no, you do.
Okay.
We'll start at 8:15 tomorrow.
Yes, thank you. I forgot. 8:15 so that we finish early and guys can go either shop or see the animals. Right. Okay. Au revoir.
Hello, everyone. For framing AMR team, please move ahead to front of the row so we can get a smaller group here. And we will have a presentation soon from Sarah Pauling, WHO, to introduce the people-centered framework to us. So as soon as we find our own group, please do move ahead. Thanks. All right, welcome everyone to the Framing AMR group work. And I hope Sarah is already with us online. Sarah, can you hear us?
Hi, I can hear you. Can you hear me? Can you see me?
Let's test with the tech here again.
But it's a pre-recorded. She's also pre-recorded.
But now she's on.
All right, so
Welcome, Sarah. Thanks for joining us online. Please go ahead.
Thank you and welcome everyone. Thank you for having me. In fact, I've shared the recorded presentation, so I would suggest perhaps that we play that and then I'm happy to answer any of the questions afterwards. Thank you.
That's great. Thanks.
Good afternoon, distinguished guests, colleagues and friends, and thank you to the organizers for inviting me to this year's ReAct Africa and South Center AMR conference. I'm sorry that I cannot be there with you in person, but I'm delighted to be able to present to you briefly on what we're currently working on at WHO and hope to publish in October is the people-centered approach to addressing AMR in the human health sector, as well as the related WHO core package of interventions, formerly known as the People-Centered Framework. As a background, and this is probably nothing new to many of you, is that globally we've made a lot of progress when it comes to the development of national action plans. Roughly 170 countries have now developed their national action plans, and likely this number is higher as the new data comes in through tracks. And thank you all to submitting that data this year. What we see, though, from the progress over the last 5 to 7 years is really that implementation has been fragmented, it has been siloed, ad hoc, which has many reasons, but we do need to ensure that we start having more of a comprehensive approach. We also know that the national action plans haven't been costed or budgeted in many countries and have not really been well sourced. Here, as you can see, is that only 10% of countries who actually have a national action plan had any level of financing related to this from their national budgets. And of course, there it was often also only minimal. In addition, the interdependence of various AMR interventions were often not considered. One example is that there are many countries that have invested, and it's important, we need this, invested in AMR surveillance systems so that we know what the current situation is on AMR at the country level and within local areas. But often this data has then not been used for antimicrobial stewardship activities to inform appropriate prescribing, just one example. And so what we need is a more comprehensive and programmatic approach That also really puts the people and their needs at the center of the AMR response and moves us away from what has been more traditional drugs and bugs discussion that many of our policymakers still don't quite understand. It's an overly complex and scientific area otherwise. And this is why WHO has developed a people-centered approach for addressing AMR in the human health sector. It comprises of a core package of AMR interventions, 13 to be exact, and I'll introduce those later on. And we hope that this core package of interventions really will help support prioritization when it comes to the revision of the next phase of national action plans that many of you are currently undertaking. In addition, in identifying the prioritized interventions for countries, we hope that the people-centered framework and the core package will really place people needs, but also health system challenges at the center, and ultimately improving patient care, but more importantly also patient outcomes. We also hope, going hand in hand, that this will reduce the negative impact of AMR on patients, and also promote community, civil society, and private sector engagement amongst a broader group of stakeholders that need to be involved in the AMR response at the local, national, regional, and global level. And finally, also looking towards the SDGs is leaving no one behind by promoting a more holistic approach when it comes to equitable access to preventative services, timely and quality diagnosis, treatment, and care for all when it comes to drug-resistant but also susceptible infections. So let me briefly introduce you to the methodology that we've used to develop the people-centered approach. This is a 5-step process that many of you have been involved in one form or the other. We at WHO developed a multidisciplinary technical working group really covering all areas that are needed for a comprehensive approach to AMR. And with this group, we then first identified people and system challenges, which I'll show you in the next slide. From this exercise, we then identified 119 important AMR interventions that were then scored and prioritized into step 4, really overarching 13 core interventions of the people-centered approach, along with supporting priority actions. And this overarching document, core interventions and priority actions, were then put forward for global consultation that many of you participated in, and thank you for that. We then also had input through the STAG on AMR in June, and now are hoping to launch the final report in October 2023. So as I mentioned, step 1 was really looking at the people and system challenges, and this is something that hopefully will also be beneficial at country level, really to see how we can bring in the people and system challenges as needs in identifying then the prioritized interventions. And so we call this the root cause analysis, looking at these challenges and needs along the AMR people's journey, starting with prevention of infection. So here we know that there are both people and system challenges, such as from the people challenges side, perhaps poor food safety practices, and also lack of awareness on hand hygiene. But on the flip side, in system challenges, there may also be weak immunization programs, but also lack of clean water. I won't cover all, but just to highlight a few more. For access to health services, for the people challenges, sometimes the lack of trust in healthcare facilities can stop someone from seeking out a healthcare professional. But on the system challenges, these might be far away. There may be weak referral systems. Also, actually, antimicrobials and the diagnostics may not be covered in health benefit packages, leading to out-of-pocket expenditures of the individuals and families, etc., etc. And so going through this, we then identified the interventions under what we call the 4 people of the people-centered framework, which formed the structure of our people-centered approach, formerly known as the framework. Pillar 1, focusing on prevention of infections. Pillar 2, access to health services. Pillar 3, timely and accurate diagnosis. Pillar 4, appropriate and quality assured treatment. And these pillars are underpinned by two foundational steps. The first one on strategic surveillance and research information, and secondly on effective governance, awareness, and education. And within the pillars and foundational steps, we then identified the priority activities for each intervention, looking at the implementation at the national or subnational level, secondary, tertiary, and healthcare facility level, primary care level, and community level. And through the 5-step process, we have now landed on 5 foundational and 8 core high-level interventions that form this core package of interventions of the people-centered approach. In Pillar 1, on prevention, this includes WASH, IPC, and immunization. On Pillar 2, on access to health services, is ensuring that actually AMR diagnosis and management is included in health benefit packages and other financing schemes so that the diagnostic services and antimicrobials are actually affordable for all. And secondly, that there is an uninterrupted supply of quality assured essential antimicrobials and health products, including diagnostics and vaccines. Thirdly, timely and accurate diagnosis, also to ensure that there is quality assured laboratory system and the trained staff that go along with it. And in Pillar 4, this includes treatment guidelines, antimicrobial stewardship programs, but of course also importantly the regulations piece. And under the foundational steps, you'll see that we have the national AMR surveillance, but also surveillance of antimicrobial consumption and use systems, as well as, importantly, research into new antimicrobials, diagnostics, and vaccines, as well as behavioral and implementation science. And finally, under effective governance, awareness, and education, this includes AMR advocacy, governance, and accountability, but also awareness, behavior change, and education. I won't go into each intervention, but just to show you that we then have the high-level interventions. Here are the 2 under Pillar 4, but then there are priority actions for each of the implementation levels that were found important under those initial 119 interventions, as well as the further consultations done. So, for example, under treatment guidelines and AMS programs, we have having up-to-date treatment guidelines based on AMS, aware and evidence-based and epidemiology, but also importantly integrating the aware classification into the national EML, and so on and so forth. So you may sometimes not see what you think should be a priority or a core intervention in the title of the core intervention. That is why it's actually a priority action under the core intervention. And now, just to hopefully get to the end, considerations for implementation of the people-centered approach and the WHO core package of interventions is that really the interventions are interdependent, and when implementing them is that these interdependencies are taken into account and that they reinforce each other. For example, having strategic surveillance and research information, which is a foundational step, can then guide the update of evidence-based treatment guidelines, which is an intervention under Pillar 4, which supports AMS programs, but also having uninterrupted supply of health products, AMR diagnosis being affordable for all through health benefit packages, informs and having good quality labs, again to inform stewardship programs. Secondly, an important consideration for implementation is community and civil society engagement, and you'll see this under the priority actions within the core package, is that we need to ensure that implementation of interventions and priority actions is really taking place at the community level, but also that the community and civil society is actually involved in the development of the national action plans and the interventions, in the implementation, and also importantly in the governance structures. And we really need to empower the community to be part of the solution. A further consideration for implementation, and I'll be rather fast here as I'm already over time, is really to also support the integration of AMR interventions within the primary healthcare and health emergency preparedness and response effort. And again, here the people-centered framework will support identifying those synergies in really enhancing efficiency, finding mutual benefits, and also being able to then identify and tap into existing funding streams that might be available through, for example, primary healthcare or health emergency preparedness response efforts. And to conclude, we hope that the people-centered approach will help to enhance political commitment by focusing on really the people and the communities, and also changing the narrative of AMR to be people-focused rather than drugs and bugs focused, to promote a core package of AMR interventions that should be prioritized within national action plans based on the country health system and people challenges and needs, and also to ensure the implementation of interdependent interventions. Thirdly, to integrate AMR interventions into primary healthcare, universal health coverage, and health emergency preparedness and response plans, budgets, but also governance structures, to promote really the equitable access to affordable and available health services and medical products, supporting prevention, diagnosis, and treatment and care of susceptible and drug-resistant infections. And finally, but most importantly, is fostering meaningful engagement of the community and community-led organizations and private sector. And with that, I finish my presentation and thank you very much for listening.
Thank you very much, Sarah. Are you staying on for a few questions, or can we move on first to the second presenter?
I'll still be here, so happy for you to first move to data, and then I'll be here afterwards. Thank you.
Great. All right, so we have the next presenter, Gada from ICARS, and she will be introducing framing AMR, guiding countries to better drive policy and practice. Thanks, Gada.
Yeah. Will you be putting the slides on? Oh, I can't see. No, this is the session before. Yeah. Try this one. That's the first one. Yeah, that's the one. Yeah, thank you. Thank you. Thank you, everyone. Thank you, Sarah, for introducing this session. Here I will be talking a little bit about how we are framing AMR to bring the public with us as well as policymaker. Sorry, can you hear me? Yeah. We've all been seeing these figures. We've all been looking at the burden of AMR. And one would wonder what more figures can show us for us to take action. This is the latest estimate, of course, that in the morning was presented to us, showing from the Gram study how important it is to track where the burden is in different locations. But talking about AMR is not a new thing. Over the last few years, we've been literally overwhelmed by the amount of information that's coming to us from the science, from the policymaker, as well as the media attention. The World Bank is estimating that by 2050, AMR can result in 28 million people in poverty. These are big figures. The IACG and the recommendation said there is no time to wait anymore. We need to move. Articles across the world, across different culture, have highlighted AMR as a problem. Well, why are we not moving quick enough? The reality is AMR has been framed over the last few years under different hats. In the healthcare setting, AMR is a healthcare problem. It impacts human health. We are having a war on microbes. We ended up with so many terminology about going to wars with microbes year after year after year. We want to impact the patient health. We want to work on epidemiology. The battery is going low. Can you just plug it in? So that I don't lose it halfway, yeah? Yeah, okay. So that we don't actually, so that we maximize impact on patient. A lot of people have discussed AMR and epidemiology of AMR, and people were engaging with the general public, with medical professions. But AMR has been as well framed as a development issue, where we are facing AMR as an obstacle for development, health for all. We are here signing up to leaving no one behind. It is a problem that's across border. It is a development problem. And we want to guarantee access to the medicine as well as, make sure that development are not hindered. And these are a lot of players that are coming on board, such as NGOs, international organizations, low middle income countries where the burden is at highest. AMR has been framed as an innovative approach. We need the next drug. This is what we keep on talking about. The next drug, the next pill will solve our problem. But for that, we need more money. We need push-pull incentive. We need to make sure there is a sustainable market. AMR has been framed as a security issue. This is an area I have issues with because we're pointing the finger. Who's bringing the AMR? Who's responsible about the AMR? Who's us and who's them? Didn't we see that during COVID? It's the same terminology again and again. But actually, it is a security for our food system, for cross-border trade, for moving from one area to another. And an AMR has been as well framed as a One Health challenge. We keep on reminding ourselves it's not only human. We keep on reminding ourselves that we live within one ecosystem and we should be looking at AMR from a holistic perspective. So framing have happened over the last few years. But in a study that Wellcome Trust, which is one of the biomedical charities based in the UK, but has a lot of global outreach, they looked across 7 countries and did a lot of public engagement with some of the major challenges, including antimicrobial resistance. They asked the public about antibiotic resistance and how high do they actually score it as an important topic. This is quite encouraging that antibiotic resistance is from the top 5 in many countries. But when we switch to antimicrobial resistance, this drops to 40%. People understand the drug, they understand antibiotics, but the terminology that we keep on using of AMR and antimicrobial resistance doesn't actually resonate very well. Now, of course, these top priority, whether it's cancer, whether it's air pollution, these are critical. But despite these figures, we still have not given AMR its best share of our engagement. But anyway, what do we mean by AMR? And why does anyone have to care about it? Because for many people in the world, For many people in the world, the terms doesn't mean anything. I can assure you when you translate it into Arabic, and which Dan would know, it's 3 words. If you want to explain it to your grandmother, to your aunt, to your uncle, and we always had antibiotics in the fridge when we were little in Lebanon, waiting there to be used in case of emergency. Well, nobody really understands it. I think it would be good to have a slide. No, but then sure. So the problem of AMR has been quite difficult for people to understand and have been very difficult for people to identify with. But the problem of even framing what we mean by AMR is not only limited to the AMR field. The climate change had that similar problem. Tobacco, using seatbelt in cars had the same problem. But it's only when things have shifted and suddenly, for example, for tobacco, we moved from, this is my freedom as a smoker, and it's my right and my health, to moving into secondary smokers. And now you are actually impacting the society that's around you. There's more a community and communal responsibility about it. We felt the same about COVID. It wasn't only about us getting infected. It's about us getting infected and giving it to your mother, to your grandmother, to the community you are around. So language matters. Different framing matter depending on the audience that you are talking to. And especially when you're communicating about AMR, that cuts across human, animal, environment, food, etc., it becomes even more problematic. What have we learned from COVID? Because COVID really is a great opportunity for us when everybody was talking about science. Suddenly people were talking about PCR testing, infection prevention control, washing your hand, close distancing, social distancing, things that the public usually is not involved in. And even ministers were talking about washing hands. I mean, the amount of interest that was shown by high-level ministerial people, even in Europe, was a bit amazing considering these topics and intervention did not come out of the blue. We always, in the scientific community, have been talking about infection prevention and control. But we have been talking amongst ourselves in many instances, and we haven't been able to involve others in the dialogue. I do need to switch to the next slide. Sorry, I do need those slides. Yeah, can you just, yeah, I need to show it on a big thing. No, the one that you closed. Yeah, can you just click on this one, please? Okay, thank you. So I want to touch upon one study before we move to where ICARs come into this. And this is very much on a framing study. When I used to work at Wellcome, the team initiated it. And then when I left, it was great to see that report being finished. And this is where they looked across 7 countries and developed the different ways of actually framing AMR. So the framing was, how do we explain AMR and present it on the specific team and different angles? And then what we wanted to understand how best to frame it to drive policy, action, and public engagement, as well as sharing finding with the AMR community to have better and more collegiate response. And there was a lot of work that had been done over a couple of years, actually, where they have done a lot of interviews with experts. They checked all the media and social media. They did quantitative, qualitative analysis, and they tested the framing on over 12,000 people across 7 countries. And what they found is that there were 5 main framing principles that Wellcome recommended in their report. framing drug-resistant infection as undermining modern medicine. This is critical because when you do explain AMR on its own in isolation, it doesn't necessarily resonate with the people and how they are looking at their health. So AMR is cross-cutting. It goes beyond one disease. It might affect your treatment if you have cancer. You might affect other treatment if you are vulnerable, but as well, it can actually affect everybody. Illustrating examples that actually identify with people. If we're talking about urinary tract infection, spell it out. This is actually what you're talking about. This is the burden. Putting AMR with UTI will help, but you need to start with the burden, with what is the clinical symptom, where is the suffering from that patient. Explain the fundamentals of AMR succinctly. And this is actually difficult because you need to try to explain it to your grandmother, and then you realize how embedded we are within our terminology that you feel such a failure to not being able to explain something you've been working on for 10 years to your family and friends. And include explanation that will bring the human part of it and how actually the role of the person in supporting some of the action. It's a universal issue. It's not only affecting one person, it affects any person, including yourself, and focus on the here and now. And that's the issue that have been happening with modeling. They are really informative for policymakers to plan ahead. But at the same time, it's very easy to put it off. Oh, this is in 2050. Who will know what will happen in 2050? It's happening now, the burden is now, and I think positioning that challenge as it is right now, right here, will be the crucial thing. And then encouraging immediate action, which is where I'm really interested in spending in the last few minutes, and this is where ICARS, a lot of its work is embedded. So they have given a nice example where they have a statement, and I will encourage you to go and see the report on the welcome side, where it tells you how you even present AMR as a problem and how you actually explain certain things for really maximum impact. So framing AMR for action. We heard about top-down and bottom-up approach a few times today, and I'll put it again because this is at the core of what ICARS stands for. Influencing policymaker, working with policymaker, but very much embedded within the research, the civil society, and the community. Without these two, top-down and bottom-up, nothing really is going to move. And that's the same for other challenges and not only for AMR. And in order for these actions to be sustainable, you do need a lot of criteria. You need the political will and ownership throughout the stakeholder chain. And we actually heard today about donors coming with their agendas to say, this is what I want to fund. But it's critical that when the donor comes, the ownership is by the country and the community to say, we would like you to do this for us because this is what we need. It needs to be context specific because AMR is not the same thing everywhere. And evidence-based, as Dr. Sujit earlier highlighted. It needs to build on the capacity of the country, understand people's behavior and how it is acceptable. When we're talking about smoking, coming from the Middle East, smoking is second nature to people. You cannot use the same messaging and the framing that you use in the UK where I'm living now. It's totally different culture, totally different perception. And any intervention that needs to be introduced needs to be cost effective, and it needs to really look at the One Health because AMR has a One Health spectrum. And I want to give two examples here. One example in the animal sector, where we've been working with an organization in Colombia called ProColombia that actually represent a range of farmers and slaughterhouses. And they're really interested in seeing why diagnostic platform has not been used for herd health for the swine production, and as such, they are suffering from unnecessary use of antibiotics. But if you look at the expected outcome that I highlighted in gray, you don't see AMR being mentioned. And that is very actively necessary because what the farmers need, they don't care about AMR. They need their farm to be hygienic. They need their disease occurrence to go down, and they need to make sure that their herd is healthy because this is their livelihood. So framing and positioning AMR to the need of the farmer, it will deliver on the AMR agenda, but the identification of the need has been tailored to the need of the farmer. Similarly, in the project that was earlier on delivered in Zambia, and we have a complementary project which our responsive dialogue team in Eden University will deliver later on tomorrow, I believe, and we're really grateful for the great work that they have done. That work is really to improve the understanding and the engagement of the community in antibiotic and AMR. And that's why the solution of such a problem has been co-created between the community, the healthcare provider, and the facilitator. And I want to finish by saying AMR is a cross-cutting challenge. When we are framing it as policymaker, it cannot be in isolation. It cannot be in isolation to the other challenges that's happening. We had nice breakout session before aligning AMR to IPC and WASH. We talked a lot, and Professor Mendelssohn talked a lot about the fact that we need health system strengthening. It is cross-cutting. Poverty leads to AMR, and AMR leads to poverty. Hunger and AMR are closely related. It doesn't mean we should be sitting there waiting for hunger to be solved to act on AMR, but it means that when we are thinking of intervention, we should be considering how best to align some of these interventions with AMR or incorporating some of the AMR lens into some of the intervention. And I picked here a few studies that have recently been published. It's nice to start seeing how poverty AMR are connecting, how antimicrobial residues and wastewater are very much connecting, and how sanitation and hygiene and AMR is connecting, and really some nice work to be done on the farm as well, looking at herd health and AMR. And with this, I will end my talk. Thank you.
All right. Thank you so much, Gada, for the excellent presentation. And we are running a bit behind time, so let's just dive directly. I hope Sarah is still here with us. So the question is mostly around what kind of the framing is needed to create a vision and practices to leverage action at either political and individual level. As Gada has kind of gave us quite a lot of examples, the messaging for AMR has largely been very technical. And how do we really bring the basic human understanding to AMR? We really need to shift our view to a more people and health-centered view that is relevant to the people and politicians that we're talking to. So WHO's people-centered framework for addressing AMR provides a holistic core package and pragmatic approach to facilitate mainstreaming of AMR interventions into broader existing efforts. And in this session, we're touching on two aspects of framing AMR. The first one, framing AMR as a societal challenge to inform policymaker. And this aligns with the work that many are already deliberating in terms of how we frame AMR, how we explain it, how we emphasize the universal issues, focus on what can be done now and encourage action. And we have learned quite a lot from the framing resistance from the Welcome report. And this year in May in Uppsala, we also had a dialogue meeting that have a specific narrative discussions around that. And the second one, framing AMR as a cross-cutting issue, as Gada also walked us through, this brings more horizontal needs to position AMR on cutting across multiple SDGs, for example, as well as other challenges and programs like climate change and UHC, etc. So in line with this, we had a few questions that's opening up to the group. And the first one, we can take a bit of the deliberation around the people-centered framework. And does this really integration provide for optimal strategies for the achievement of people-centered framework in Africa region? Any comments, any reflections around the people-centered framework? You can raise your hand, or if there's any online interventions. Yes.
Maybe you can go through the way you framed the question again so that we understand as we respond.
Yes, so the first question is around the people-centered framework, and that's very much what Sarah has walked us through in her presentation. And does this framework, the integration, provide optimal strategies for the achievement of patient-centered framework in Africa region? So basically kind of framing AMR using the WHO's framework that's providing a bit of the practical and pragmatic approach, integrating, for example, the PHC, the UHC, and other interventions. Maybe Sarah, if you're here, you can also kickstart the discussion.
Yeah, can you still hear me?
Yes.
Super. Yeah, maybe just to add a few more comments, and apologies, I still go interchangeably between framework and people-centered approach as we're still finalizing the title. But I hope what I was able to instill on you in the presentation is that, of course, a lot of the national action plans before, and as they should be, were really looking at the global action plan for guidance on identifying what should be the priorities. But of course, we've now also acknowledged within the human health sector that there were gaps. And I think it was mentioned yesterday, for example, that quality of antimicrobials and looking at substandard and falsified antimicrobials was not part of the interventions of the global action plan. Also looking, for example, at whether the prescriptions of antimicrobials are actually covered by health insurance schemes was, again, not part of the gap. And so the people-centered approach and the core package of interventions is really trying to identify and then provide to countries what is, for the human health sector, really the core intervention packages that all countries should review and see what fits based on their people and system challenges. So we hope that this will be beneficial to countries as they are actually looking to update their NAPs to ensure that the interventions within the National Action Plan really are focusing on what the people in the communities need when it comes to the prevention of infections, accessing healthcare services when they need to, for the diagnosis, treatment, and care of infections, both of susceptible and drug-resistant infections. So I hope that is an additional comment that helps to spark the conversation on whether this will be helpful in when you are updating your NAPs, and also perhaps in how you frame AMR and the importance of these interventions to your policymakers. Thank you.
Thank you very much, Sarah. Any reflections from the floor or online? There's a hand from Tracy.
Thanks, Sarah. Thanks, Gada. Maybe, I don't know, it's something that I always wonder. Gada just now actually did mention, like what the framing for Wellcome Trust reflected was that people identify with antibiotic resistance, right? Or drug resistance or whatever. However, now back to Sarah, then WHO has then sort of guided us or directed us just recently to instead now work with antimicrobial resistance. So don't we think, are we preaching water and drinking wine? I don't know. I keep asking myself, are we actually doing ourselves a disservice? Or is what as maybe is what Sarah and the WHO team saying is, of course, then it has to be contextualized. But honestly, when you look at it, most of our populations do not understand antimicrobial resistance, but they do understand antibiotic resistance or drug resistance or superbugs, at least from what we saw, especially with the framing from Wellcome Trust. I don't know what others feel about it. I don't know whether I'm the one who's confused. But yeah, I'd like to hear. Thanks.
Yeah, maybe I can come in and could not agree with you more. I fully agree that AMR are I hope you can hear me. Tracy, I couldn't agree more with you. I do agree that antimicrobial resistance, and as I think Gada had mentioned, it doesn't translate also into many languages. There are languages where there is no word or meaning, or it becomes an entire sentence. And so I know WHO has been, and the quadripartite has really been pushing to move towards antimicrobial resistance, but perhaps just to say that what we are trying to also, and really are trying to bring this language into the people-centered approach, is looking at drug-resistant infections as sort of the main term we are using, and that we're starting with drug-resistant bacterial infections, of course, as well as susceptible. And so the people-centered approach and the core interventions primarily are garnered towards antibiotic resistance and not antimicrobial resistance. But all of this needs to be under the umbrella of sort of the broader antimicrobial resistance response at the country level, because of course we also should be linking in with, for example, malaria, TB, HIV, etc. But we are trying also at foremost to focus on antibiotic resistance when it comes to the people-centered approach. I cannot speak to all the different initiatives with WHO, but this particular people-centered approach is focusing primarily on antibiotic resistant infections.
Thank you, Tracy and Sarah. And it's really, it leads to our second question about how can we as AMR experts support a better framing of the challenge for both immediate action and maximum impact? What kind of enablers and barriers should we be cognizant of, and as such leverage and mitigate respectively? So that's kind of, I can also reflect a little bit regarding how people are kind of receiving the message, whether we're using the scare technique, such as 1.27 million people are dying, or X million people will die unless we do something. This has been quite useful and it's possibly still needed. But we also need to include some sort of the positive message, a message that brings hope and the conviction that we can do something about the problem. And this, especially for policymakers, it's very important to see such a connection between the action and effect. If we do X, Y will happen. Something that we should co-create the narrative and solutions by inviting the different stakeholders, inviting our communities to discuss and learn together about the issue and what we can do about this. So any reflections? Maybe we've already touched a bit upon the antibiotic resistance, about quite a lot of the examples that Gada has walked us through. Yes, back there first.
Thank you, both Sarah and Dr. Gada. My name is Lloyd. I'm from here in Zambia. And the question is appropriately cross-cutting to both Dr. Gada and Sarah. We've heard a lot, we continue to hear a lot, and we continue to listen a lot about what we can do collectively. The question, and this remains a question, what can be done in terms of capacity so that us in these parts of the world can contribute equally? It's more like the climate question, isn't it? Some people are contributing to the damage more. So with regard to AMR, everybody is at risk. If we get pockets of money here and there, what are we doing to make systems more equal and to make capacity more equal? Interventions are important, but as long as interventions continue to be imported, they continue to be an important solution. It is time that we need to see more from where we sit, where we are, and we do need to lead what will become, an owned intervention by not just Africa, but people in deprived communities. Deprivation in resources is deprivation in capacity. So we do applaud entities such as ICAS, the WHO, and other entities, but we are ready to work on an equal platform to contribute to what's needed